Good morning, everyone. It's my privilege to extend a warm welcome to all of you for this CME and workshop on World Cancer Day, being hosted at AIIMS Bhopal under the theme of Advancing Cancer Care Through Precision Medicine. This gathering brings together esteemed experts to foster awareness and advance scientific knowledge in the global fight against cancer. To formally To formally inaugurate this event, let us begin with seeking the divine blessings. I now invite our esteemed Executive Director, Sir Dr. Ajay Singh, Dean Research, Sir Dr. Rehanullah, the Secretary and Member of South Asian Chapter of Global Cancer Consortium, Dr. Jyoti Kode and Mahadev Rao, Sir, and our distinguished speakers for today, Dr. Vivek Rangnekar and Dr. Sridhar Ganeshan, Sir, who have traveled all the way from United States to grace this occasion, to kindly join us for the light lighting ceremony. To deliver the welcome address and outline the scope of today's event, may I kindly invite Dr. Debashish Biswas, Sir, to join us.
Respected Director, Sir, Professor Rehan, our Dean of Research, Colonel Ajit, our Deputy Director of Administration, Dr. Jyoti Kode, Madam, the Secretary of the South Asia Chapter of Global Cancer Consortium, our very dear friend, Dr. Mahadev Rao, Dr. Vivek Rangnekar, whom we had the privilege of hearing as a keynote speaker in our previous edition of the CME of Precision Medicine, Dr. Sridhar Ganeshan, whom we are used to hearing for the in the Zoom classes that we have between our faculty members and members of the Global Cancer Consortium. Dear participants, my colleagues, faculty colleagues, and above all, our dear students. As I stand before you today, my thoughts go back to the first CME that we held under the aegis of Center of Precision Medicine around 5 to 6 months back in the month of August 2024, where oncology was one of the 4 sections, and along with mental health and chronic metabolic diseases and pharmacogenomics. We built upon that momentum that we created around 5 to 6 months back, and quite fitting and apt with the requirement of the time, we now have a day-long CME dedicated only to oncology, and it is very befitting that it aligns perfectly in significance with the occasion of World Cancer Day today, which is being celebrated by WHO across the world. Oncology has been one of these spheres which has seen a paradigm shift with the advent of precision medicine. We all know that cancer used to be seen as a singular disease which hardly had treatment options. And now with the evolution of genomic-based insights, biomarker-driven treatments, it has evolved into a spectrum of conditions which provide opportunities for individualized care and thereby optimizes outcomes and reduces unnecessary interventions. And it is recognizing this development, this very significant recent development, that we have titled this CME as Advancing Cancer Care Through Precision Medicine. If you look at the curriculum that we have for today's, we have got didactic lectures addressed by the best in the business. We have Professor Rangnekar, who has come from University of Kentucky. We have Dr. Sridhar Ganeshan from the University of New York. And we have our very own Dr. Saikat Das. Along with that, we have got 2 very important case-based panel discussions on colorectal cancer and lung cancer. And followed by, we have got 2 very state-of-the-art parallel workshops on image-guided radiation oncology and 3D organoid applications in cancer medicine. So there's a lot to do in the next 6 to 7 years, 6 to 7 hours we have for today's day of learning, eventful day of learning. So I won't waste much of your time, and without further ado, I would also be failing in my duty if I failed to introduce another very milestone that we are going to achieve today, the signing of MOU with the South Asia chapter of Global Cancer Consortium, which has been at the forefront of spearheading collaborations across institutions in cancer education, cancer research, and cancer clinical care. So with this, I welcome you all once again to this happening day that we are going to have today, and I welcome you all to a very delightful learning experience. Thank you.
Thank you, sir. Next, we have privilege to hear from Dr. Jyoti Kode Madam, Secretary of South Asian Chapter, who will share valuable insights about its initiatives and contribution to cancer research and collaboration in the region. Ma'am.
Good morning, all. And I'm very delighted actually to be amongst all these youngsters who are ready to join hands with Global Cancer Consortium South Asia chapter. So our own GCC president, Dr. Vivek Rangnekar, and Dr. Mahadev, who is a executive committee member, and I also represent as a secretary of Global Cancer South Asia chapter. Our president, Dr. V. Prasanna, she couldn't come, but her best wishes are always with us. And we would say that Global Cancer Consortium was initiated in 2019, and later on it, with the activities going on, it really spread to we formulated GCC South Asia chapter, then it went to North Carolina chapter, Europe chapter, and East Asia chapter also. And there are various activities we conduct through GCC South Asia chapter that we have conducted to international conferences within India. 3 now, because one was in Manipal Mahe, one was in Attrek. Just recently, last week, we had one very magnanimous response to GCC conference at the Amity University, Noida. Next, we will be having in Kolkata, so we will be covering all the zones of India. And they also have initiated cardio-oncology course, and they also have they have conducted some 2 workshops, omics workshop, computational biology workshop. And the main mandate has been education, promoting research, inter-institutional collaborations, and mainly outreach program, youth science program. So I think I'm happy that AIIMS Bhopal is joining in this venture, and I wish all the best, and also I welcome you all, AIIMS Bhopal in the GCC South Asia chapter. Thank you.
Thank you, ma'am. Next, we have Dr. Saikat Das Sir, Additional Professor in Department of Radiotherapy, who will elaborate on this year's theme of World Cancer Day, United by Unique.
Respected Director, sir, distinguished guests and dignitaries on the dais, off the dais. This is a very remarkable day. This is World Cancer Day. And as enunciated by UICC, the theme of this year is United by Unique. Now, this is a very important message because cancer is not a single disease, as we heard, because it has changed the dimensions, and then it requires multidisciplinary management. Not only the medical, surgical, radiation oncologists, but also basic scientists and so many other caregivers and family, they are involved. So each patient is unique and they have a unique story to tell. And that actually transcends not only to the physical challenges, but also the mental, social, and overall well-being. So that is why we need to be united. And in that step, it is a very welcome initiative that the department, that the Center for Precision Medicine is organizing, not only to discuss science, but also to move the services forward so that we can translate the benefits of the science and technology be it through the molecular tumor boards. We already have functioning tumor board. We need to upgrade that. That is one of the new things which are coming up, so that the benefits of the scientific discoveries and the research is equitably distributed to the population. And with this note, I welcome all of you on behalf of the organizing committee. Thank you so much.
Thank you, sir. Now we proceed to the significant program of today's program, the signing of Memorandum of Understanding. This collaboration marks a milestone in our shared vision. Let us witness this memorable occasion together, followed by a photograph to commemorate this moment.
थैंक यू वेरी मच। एक्चुअली हमारा एक प्रोग्राम 10 बजे से डिप्टी सीएम साहब आने हैं, इसलिए थोड़ा सा सबसे पहले तो मैं एम्स भोपाल की तरफ से सभी एस्टीम्ड फैकल्टी मेंबर्स, एक्सपर्ट्स, फैकल्टी मेंबर्स ऑफ एम्स भोपाल, सभी स्टूडेंट्स, पीएचडी स्कॉलर्स और सभी लोगों का जो यहाँ पे आज इस हिस्टोरिकल इवेंट को कवर करने के लिए और अपनी नॉलेज को एनरिच करने के लिए आप आए हैं, मैं उन सबका बहुत बहुत स्वागत करता हूँ। हम लोगों ने जब प्रिसीजन मेडिसिन सेंटर का कंसेप्ट हमने परसीव किया था, तो कहीं ना कहीं हम लोग का ये मतलब था कि एम्स भोपाल इस जर्नी में एक लीडिंग रोल प्ले कर सके और कैंसर जो मैनेजमेंट है उसमें कहीं ना कहीं हमारा कंट्रीब्यूशन ऐसा होना चाहिए जो कि ना सिर्फ पेशेंट के लिए बल्कि पूरी सोसाइटी के लिए बेनिफिशियल हो। तो उस दिशा में हम लोगों ने जो ये प्रिसीजन मेडिसिन के अंदर डिफरेंट सेक्शंस को हम लोगों ने इनकॉर्पोरेट करने की कोशिश की और उसमें से एक ऑफ कोर्स कैंसर मैनेजमेंट अपने आप में एक बहुत ही इम्पॉर्टेंट सेगमेंट है। लेकिन मुझे ऐसा लगता है कि सेंटर ऑफ प्रिसीजन जो मेडिसिन है उसका काम सिर्फ प्रिसाइज ट्रीटमेंट को डिफाइन करना ही नहीं है, बल्कि कहीं ना कहीं प्रिसीजन मेडिसिन का काम प्रिवेंशन से शुरुआत होती है और अर्ली रिकॉग्निशन डायग्नोसिस से होते हुए ट्रीटमेंट पे आती है और ट्रीटमेंट पे ही ख़त्म नहीं हो जाती। हमको कुछ ऐसे बायोमार्कर्स के ऊपर काम करने की आवश्यकता है जहाँ पे हम लोग प्रोग्नोस्टिक वैल्यू को डिटरमिन कर सकें और प्रोग्नोस्टिक वैल्यू को डिटरमिन करते हुए हम लोग जो प्रोग्नोसिस आगे बता सकते हैं या फ्यूचर या रिहेबिलिटेशन जो इन पेशेंट्स का होता है उसमें कहीं ना कहीं हम लोग स्पेशलाइज्ड ट्रीटमेंट, कस्टमाइज्ड ट्रीटमेंट पेशेंट को ऑफर कर सकें। तो मैं जितने भी ऑर्गेनाइजर्स हैं, जितने भी लोग हैं इसको सुन रहे हैं, मेरी ये एक अपील है, मेरी इच्छा है कि हम लोगों को काम करना चाहिए, प्रिवेंशन से शुरू होना चाहिए कि कैसे कौन से ऐसे बायोमार्कर्स हैं जो कि कुछ जेनेटिक लेवल पे हमारे यहाँ के जो ट्राइबल एरियाज़ हैं उनकी जेनेटिक स्टडी करके हम लोग क्या कुछ ऐसे प्रिवेंशन के लिए हम बायोमार्कर्स निकाल सकते हैं जो कि उस पर्टिकुलर एरिया में कम से कम इफ़ेक्टिव हों और उससे हम लोगों का जो हमारा पर्पज़ है वो कहीं ज़्यादा बेहतर होगा और हम लोग शायद सोसाइटी के लिए ज़्यादा यूज़फुल हो पाएंगे। आज का जो हिस्टोरिकल इवेंट है जिसमें हम लोग ये एमयू हम लोगों ने साइन किया है और इस एमयू के साइनिंग की का जो इम्पोर्टेंस है वो तब है जब हम ना सिर्फ साथ में बैठ के अपने आइडियाज़ को एक दूसरे से एक्सचेंज करें, फैकल्टी को एक दूसरे से एक्सचेंज करें, हमारे जो यंग स्टूडेंट्स हैं, इन जो लोग आगे चल के हो सकता है कि इसी फील्ड में अपना नाम करना चाहें, उन लोगों को हम लोग यदि डिफरेंट सेंटर्स में ओरिएंटेशन के लिए भेज सकें, उनको एक्सचेंज प्रोग्राम हम लोग शुरू कर सकें, तो मुझे ऐसा लगता है कि ये ज़्यादा अच्छा होगा। तो इस एमयू में मुझे पूरा विश्वास है कि आप लोगों ने इन चीज़ों को भी इनकॉर्पोरेट करने की कोशिश की होगी। आज वर्ल्ड कैंसर डे है और इससे अच्छा दिन इतने अच्छे काम के लिए नहीं हो सकता था और अभी हम लोग यहाँ पे प्रिसीजन मेडिसिन के से जो एडवांसिंग कैंसर केयर थ्रू द प्रिसीजन मेडिसिन जो आज की थीम है, हम लोगों का अभी 10 बजे से दूसरी थीम है कि हाउ वी कैन ट्रेन आवर our nursing and the paramedics and the technicians about the palliative care of these patients. तो एम्स जो है वो एक कम्प्रिहेंसिव जो ट्रीटमेंट केयर है कैंसर से रिलेटेड उस पे काम करने को क्या इच्छुक है, और मुझे ऐसा लगता है कि बहुत सारे ऐसे एनजीओज़ भी होंगे जो हम लोगों को इस काम में बहुत ज़्यादा मदद कर सकते हैं, तो हम लोगों को उनको अप्रोच भी करना चाहिए। अर्ली साइंस के बारे में आम जनता को हमको पहले से बताना चाहिए कि क्या होने पे आपको वेट नहीं करना है और आपको तुरंत किसी इस अच्छे सेंटर पे जाना है। लेकिन उसके साथ ये भी कि कैंसर को सोच के कोई इस प्रकार की मिथ ना आ जाए दिमाग में, या कोई ऐसा डर ना बैठ जाए कि लोग सोचें कैंसर हो गया तो सब कुछ ख़त्म हो गया। आज के ज़माने में ये चीज़ शायद उतना मायने नहीं रखती है, क्योंकि बहुत सारी डायग्नोस्टिक और थेरेपेटिक टेक्निक जो हैं ऐसी आ गई हैं जो कि क्वालिटी ऑफ लाइफ और लेंथ ऑफ लाइफ को दोनों को काफ़ी इम्प्रूव करती हैं। मेरी बेस्ट विशेस ऑर्गेनाइजिंग कमेटी को है, और मैं विश करता हूं कि जितने लोग भी आज की इस सीएमई को और वर्कशॉप को अटेंड करेंगे, जब वो इस मीटिंग के बाद बाहर निकलेंगे तो वो कहीं ज़्यादा एनरिच्ड होंगे नॉलेज वाइज, और एक तरीके से एम्स भोपाल के एम्बेसडर बन के वो बाहर जाएंगे, जो कि हमारे जो अचीवमेंट्स हैं, हमारे जो हम लोग जो प्रयास कर रहे हैं, एफर्ट्स हैं, उनके बारे में वो आम जनता को जागरूक करेंगे। तो मेरी बहुत बहुत शुभकामनाएं, और वंस अगेन आई एम ग्रेटफुल फॉर ऑल द एस्टीम मेंबर्स हु हैव कम टू एम्स भोपाल एंड ग्रेस दिस ओकेजन. I wish everyone very happy learning. Thank you.
Thank you, sir. We also have with us 3 of our beloved patients whom we have opportunity to serve in the course of their battle with cancer. As a salute to their spirit, we take this occasion to offer them a token of recognition on this special occasion of World Cancer Day. May I call Mrs. Savita Pawar? Miss Saloni? Mr. Rakesh Sen? Thank you. As we approach the conclusion, let us hear a vote of thanks from Dr. Deepti Joshi, ma'am.
Good morning, everyone. It's a privilege for me to propose vote of thanks on this occasion. At the outset, I'd like to thank our Executive Director, sir, Professor Ajay Singh, sir, who has been very encouraging and he has motivated all of us to organize such events, which not only enrich our knowledge, but also, enhance us enhance in developing our personality in, interacting with so many people. So we are very grateful to sir. We are thankful to our Deputy Director, Colonel Ajit Kumar sir. Sir has always been very supportive. Dean Research, Professor Rehanul Haq sir. I can say that Rehan sir has been very supportive and he's been always very approachable for organizing any such event. I'm very thankful to Professor Debashish Biswas sir, under whose able guidance we have been able to organize this event. And we are very thankful to the esteemed national and international speakers, Dr. Jyoti, Dr. Mahadev, Dr. Vivek, Dr. Sridhar, who have traveled all across they have traveled from US, somebody has traveled from Manipal, somebody has traveled from Mumbai to be there with us and to enrich us with their pearls of wisdom. We are very thankful to all our delegates, all faculty members who are here in great number. We are very thankful to our students who are here to, who are here to witness this occasion. और मैं अंत में आभार व्यक्त करना चाहती हूँ अपने सारे मरीज़ों का. आप सबकी संघर्ष की कहानियाँ हम सबको प्रेरित करती हैं और हमें उम्मीद है कि हम आप सबसे बहुत कुछ सीखेंगे. धन्यवाद आप सबका.
Before we conclude, may I kindly request all the dignitaries and participants to join us for a group photograph. Thank you. This way, sir.
आजा.
हेलो.
सर का प्रेजेंटेशन भी इसी में डालना है.
is not just about targeting cancer, it's about targeting hope, resilience, and survival. A very good morning to the esteemed dignitaries on and off the dais, respected faculties, seniors, colleagues, and beloved juniors. I, Nishtha Gupta,
I am Mohammad Anas Gauri, junior residents from Department of Radiation Oncology, welcome you all to the scientific program and workshop entitled as Advancing Care Through Precision Medicine on the occasion of World Cancer Day.
2022, there were an estimated 20 million new cancer cases and 9.7 million cancer-related deaths worldwide. This day holds profound importance globally as we come together to raise awareness, foster unity, and empower ourselves in fight against cancer.
To embark the scientific journey, it is my distinct honor to invite Dr. Deepti Joshi, Professor, Department of Pathology and Lab Medicine, AIIMS Bhopal, as the chairperson of the first plenary session on the topic Monitoring Clonal Dynamics of Cancer in the Clinics. Ma'am, please welcome. Kindly come to the stage.
It's my privilege to introduce Dr. Vivek M. Rangnekar. Sir is a professor and Alfred Cohen Endowed Chair at the College of Medicine, University of Kentucky. He also serves as Associate Director at the Markey Cancer Center and is the founding chair of the Global Cancer Consortium that promotes global cancer research, education, and outreach activities. He has many acclaimed international publications to his credit and has served on numerous DoD grant review panels and NCI. Okay, so sorry. This session is by Dr. Sridhar Ganeshan. I'm so sorry for this slip up. He is Professor and Director at Center for Molecular Oncology, NYU Langevin Health's Perimeter Cancer Center, New York, USA. He is a physician scientist and Director of the Center for Molecular Oncology and Professor of Medicine at New York Perimeter Cancer Center. He actively works on breast cancer patients, and he has many international publications to his credit, and he has held multiple leadership positions, including the Omar Boyer Chair in Genomic Sciences. And I'm sure that we'll be enriched by his experience in basic translational and clinical research. And he is a great mentor, and he has mentored a lot of graduate students, residents, and postdoctoral research fellows. Welcome to the session, Dr. Sridhar, and we look forward to hear from you. Welcome, sir. And for the next half an hour or so, we'll be listening from Dr. Sridhar. Welcome, sir.
Great. Thank you so much. It's a real pleasure to be here, and I greatly appreciate the opportunity to talk to you all. And it's been a great experience meeting some of the faculty, and look forward to meeting more of the faculty and students later on today. So I'm a physician scientist. I see patients with breast cancer, but I also run a basic and translational lab focused on DNA repair, and over the past 10 years on cancer genomics. These are my disclosures. The real exciting thing that's been happening over the past decade in oncology is really a shift in our classification of the diseases that constitute our field. And really a shift in the classification of cancer from being purely based on anatomy and histology to really including elements of molecular etiology. So for example, sorry, it's here. I don't know if you can see the pointer. How is cancer diagnosed and classified? So if you have a lump in the lung, you take a biopsy and the pathologist says it isn't right. it's primary lung cancer. And then based on morphology, cells are small, not small, and then based on features of histology, you get categorized into non-small cell lung cancer, and then perhaps adenocarcinoma squamous or other rare histologies. This is our current classification of cancer based basically on organ, anatomy, and histology. But this kind of classification greatly masks the total underlying heterogeneity. For example, if one takes adenocarcinoma of non-small cell adenocarcinoma of the lung and looks at the underlying molecular drivers, all right, we can see that there's an enormous diversity of the actual changes in the DNA that actually drive the cancer and actually dictate both its natural history and response to treatments. And this is really important because ultimately cancer is acquired changes to our genome making us sick. In some ways, an infectious disease is someone else's genome making us sick. Cancer ultimately is acquired changes to our genome making us sick. And it's really important to have the features, the etiology. What are the changes in the genome between cancer cells and normal cells as part of the classification? For example, 4% of adenocarcinoma of the lung will have rearrangements in the anaplastic lymphoma kinase, or ALK. And those and only those are incredibly responsive to inhibitors that target that driver kinase. So then one could ask, are ALK inhibitors lung cancer drugs? Well, 96% of lung cancers won't respond to ALK inhibitors. It's instead a drug that treats diseases that are dependent on ALK signaling, of which ALK mutant lung cancer is one of them. All right? And this is really important because, to say lung cancer is kind of like, my wife is an infectious disease doctor. And in the old days, infectious disease was also organized around anatomy. We had pneumonia clinics and encephalitis clinics. So I say lung cancer in many ways is like saying pneumonia. Okay, it's a clinical organ-based syndrome made up of many distinct individual diseases with distinct molecular pathophysiology and distinct natural histories and treatment. All right, and that's true of breast cancer. I don't know how to treat breast cancer without understanding ER, PR, HER2, and a variety of molecular markers. All right, and I think that's where we're shifting from. And the way I think about that is that when there is no effective systemic therapy, surgical anatomy drives classification and treatment. As effective systemic therapy comes along, we then start to include elements of etiology. All right? Even in oncology, Hodgkin's disease used to be, for example, was massively carefully staged because it was local radiation therapy. As systemic therapy went away, also staging went away to just summon more, or sick or not sick. And you see that starting to happen in all our diseases as we get effective systemic therapies. And the other thing people say is that, perhaps precision medicine said, the great thing about the ability to characterize this is that the technology for rapid molecular analysis has really come along with the advent of next generation sequencing or massively parallel sequencing. Because the problem with sequencing our classical clinical specimens is that most biopsies we, dunk in formalin and use paraffin embedding. And as soon as you put specimens in paraffin, even though it preserves histology, it breaks up DNA and RNA into small fragments, and you get random crosslinks. And that had been a barrier to clinical sequencing. But next-gen sequencing or massively parallel sequencing overcomes those and really unlocks our standard pathological specimens for in-depth sequencing. And without going into the details, this is basically solved technology. You can pick your favorite megabase of the genome and get a sequence to high depth in commercial laboratories in about 7 to 10 days. And it's gotten to the point, at least in certain places, where sequencing is no longer the stumbling block. The turnaround time is limited by logistics, getting the specimen to the lab, and computation. Sequencing takes 2 days. Then understanding the computational data and generating a report takes 5 to 7 days. So it's logistics and computation that are now the stumbling block, not really the sequencing physically anymore. And this is really important because in the early days, people said, precision oncology, these medicines, they last for, a couple of months and then people immediately progress, all right? And again, my wife is an infectious disease, so we could say the same thing. AZT, when it came around for HIV, also had transient responses. But we didn't stop, targeting reverse transcriptase because AZT wasn't a great drug, right? So similarly, this is great, data from the recent phase 3 CROWN study in which they compared advanced ALK rearranged lung cancer treated with crizotinib here in the red line, which is our first generation ALK inhibitor. And you can see, people progress within 8 to 6 months, more than half. And now, compare that to now treatment with the third generation ALK inhibitor, lorlatinib. So lorlatinib is a third generation inhibitor that penetrates the brain and actually can treat the common surface front resistance mutations. And now you can see for advanced ALK-mutated lung cancer with a single agent, more than 50% of patients are alive without progression of disease at 5 years. All right? And so advances in the drugs really can also change natural history. And similarly, this is advanced disease. The big advances are really going to come in early stage disease. So this is, again, alectinib, a second-generation inhibitor in ALK-positive non-small cell lung cancer early stage, comparing adjuvant chemotherapy versus adjuvant single-agent alectinib. And again, every drug that's really good in advanced setting, if the drug is good and tolerated, works even better in the adjuvant setting. We learned that in breast cancer, and so now this is really going to change natural history as we treat earlier and earlier. So based on this, when I was at Rutgers, since 2012, we've developed a protocol for targeted genomic analysis of almost every patient who walks into our institute, where they get consented, we retrieve tumor blocks, do targeted sequencing, review them at a molecular tumor board that meets weekly. And our molecular tumor board, we see both adults, children, solid, and heme malignancies all together. All right, so we don't separate by anything. And data are on recommendation of 10 to screening clinicians. And patients are forward consented, so we can also do research sequencing, prepare xenografts, models as we need, and patients are forward consented throughout their journey, so we can see them multiple times. This initially started as a 100-patient trial when we started in 2012, and now we have over 5 to 10,000 patients gone through this and presented. And we've developed a lot of experience in understanding molecular analysis of individual patients. And in particular, we've been using this kind of platform not only to help the care of individual patients, but as a platform to drive both basic translational and clinical investigation. We understood the biology of rare cancers. We are a clinical comprehensive cancer center, so we do a lot of early phase clinical trials. So everyone on early phase clinical trials gets sequenced, and so we can understand mechanisms of resistance and response to both immunotherapy and targeted therapy. And today I'm going to talk to you about how we've learned a little bit about dynamic monitoring of patients over time, or getting really insight into how the clonal dynamics of cancer change under effective therapy. And so I'm going to talk about a case. Some of you, I might have presented this online at some point, but I'll go this in detail. This is one of the early cases that we did back in 2015. It was a pediatric patient, a 15-year-old girl who had metastatic colon cancer, a very unusual setting. All right, so I was actually attending on the adult oncology service, and it's always bad when the adult oncologist gets consulted on the pediatric service. And so a patient presented with abdominal pain was found to have a large mass in the colon and multiple liver lesions, and ultimately this was consistent with adenocarcinoma of the colon. Patient underwent a sequencing protocol, and the patient had a BRAF V600E mutation, P10 loss, P53 SMAD alterations, and the tumor was microsatellite stable. And there was no genetic reason for this. In fact, there is no known genetic syndrome that causes colon cancer in adolescence, as we know. And the patient was started on standard therapy with with the FOLFOX chemotherapy regimen, 5-FU oxaliplatin, and she actually had a nice response initially. So she had an informative serum tumor marker called CA19-9, which is plotted here on the y-axis, and this is time. And you can see initially this is quite elevated. When we initiated chemotherapy, this went down very nicely. This kind of response lasted, as is known in this disease, for about 3 months. And then she started to have progression radiographically, clinically, and serologically. The standard approach here is second-line therapy, FOLFIRI, and it usually lasts about half as long as first therapy, and after second line, there's really nothing else we can do. So we said, hey, we have a BRAF V600E mutation. Can we do something about this? This is back in 2015. At that time, we knew that BRAF inhibitors, although they're incredibly active in melanoma, with about a 50 to 60% response rate in untreated melanoma that has this mutation, with this exact same mutation, there was a less than 5% response in colon cancer, either with BRAF inhibitors or the combination of BRAF and MEK inhibitors. All right? And this is very puzzling, because here's the same driver, different cell of origin. One responds great, one doesn't respond at all. Right? And the reason for this was uncovered by René Bernard's group at the Netherlands Cancer Institute, who did this really impressive study back in 2012. And so we asked the question, hey, why are BRAF mutant colon cancers, as opposed to BRAF mutant melanomas, sensitive to BRAF inhibitors? So these are a variety. In blue is a melanoma cell line that's BRAF V600E, and when treated with increasing concentrations of vemurafenib, you see this very nice change in survival. These are all colon cancer cell lines with the same mutation. You can see the response is meh. Not that great, all right? So we asked the question, why do these colon cancer cell lines not have such a nice response as the melanoma cell lines? And so he did basically, without going into the details, he did a synthetic lethal screen for kinases. He basically said, is there another kinase in colon cancer that these cells are dependent on? And if I knock each one of them down, is there one that will make these cells sensitive to a BRAF inhibitor? And to their surprise, the big hit was epidermal growth factor receptor, EGFR, which we know plays a major role in the survival of colon cancer cells. And so he found that, hey, if you take these colon cancer BRAF mutant cells, if you treat them with BRAF inhibitor, there's no response. If you treat them with EGFR inhibitors, we know there's no response. But if you combine them, all of a sudden there's a dramatic response. And this is kind of wild, because normally when we combine drugs in oncology, we look for single agents that work well, and if they work well, we combine them. So here are two single agents that had little to no activity on their own, but combined, did really well. And the reason for this is this is the only, I don't know if the basic scientist is the only Western blast that I'll show today, but it's kind of informative in that if you take these BRAF mutant colon cancer cell lines, at baseline, there's phosphorylation of MEK and ERK as expected. When we add the inhibitor, phosphorylation of MEK and ERK goes away. So the drug is working, it's doing its job, all right? But then as this came down, there was also an active phosphorylation of EGFR and AKT. And now if you hit both EGFR and a BRAF inhibitor, you prevent activation and then you get cell death. And this is the entire concept of adaptive resistance to these inhibitors in colon cancer, in that when you have chronic activation of a pathway, of the BRAF MEK or ERK pathway, there's actually upstream inhibition of EGFR. When you now use an inhibitor, this unleashes, this reactivates EGFR signaling, and now through alternate pathways you maintain cell survival. And so this suggests in order to action this, you need to hit both BRAF MEK as well as EGFR. And this was a basic science finding that showed this actually worked in mouse models. So these are mouse models that show that each inhibitor alone does very poorly, but the combination does very well. And this changed within 3 years from that Nature paper to phase 1 trials that showed that this combination is actually active in humans. And in fact, we had that clinical trial, but there was no data in pediatric patients. And this patient was sitting in front of us, and so we realized that we had to actually lower the entry criteria of our clinical trials to age 12 for these patients. And now we know this therapy is actually activated. So back then, based on the early phase 1 trial data we had at the time, and speaking with the patients and knowing the natural history, we said, hey, can we treat this patient with just pure targeted therapy using a BRAF inhibitor, a MEK inhibitor, and an EGFR inhibitor? And with the patient's assent and her parents' consent, we initiated therapy, and she actually had a dramatic response, all right, with a dramatic response both serologically, radiographically, and clinically. But the problem was, of course, this did not last, right? So you can see that response lasted by the serum markers about 4 months, and then she started getting progression with an increase in her tumor marker and then an increase in a radiographic response as well. At this time, we also started to monitor her by serial cell-free DNA analyses, all right? And I'll just remind you guys what circulating cell-free DNA is. So all cells, when they die, release DNA into plasma. Cells die by apoptosis. They'll release little short fragments of DNA. If they die by necrosis, you get these larger smears. So if you take plasma DNA and do a sizing column, you'll get a biphasic, you'll get a short peak of apoptosis, and then a larger smear of DNA fragments that come from necrosis. All right? So this is a very, very dynamic marker because circulating DNA has extremely short half-life, maybe minutes to hours. And therefore, it's a very dynamic marker. There's mostly enzymatic degradation and hepatic degradation. There might be renal clearance. If there was, and there's a lot of interest in, hey, can you actually detect this in urine? All right, but it's not clear there's actually good renal clearance. And the idea is that, hey, both normal cells in our body are dying, as well as tumor cells in our body are dying, and they're both releasing DNA. And if you can capture cell-free DNA, you can find two things. One, if you see mutations that are associated with the cancer, you can say, you can detect cancer. And the second thing is the proportion of DNA that's mutant is indicative of the total body burden of cancer. So the allele fraction of mutant DNA in your blood is a reflection of how much cancer there is in your body. So it gives you a quantitative as well as a qualitative assessment of what's going on in the cancer. Our tumor marker just gives one number, it goes up or down. But this gives you, also tells you up or down, but then tells you then what the mutational status is. Oops, excuse me. And so we started following her, and these are, this is how the data look like. And so what these data are fish plots. Each of these colors is a different mutation. So the dark blue is the BRAF alteration, the light blue is P53, the light green is the SMAD mutation that she has. And you can see that when her tumor markers were declining, there was very little detectable cell-free DNA. At the nadir of her tumor markers, there was no detectable cell-free DNA. And then when she started to relapse, all of a sudden there was clearly detectable cell-free DNA and these mutations present. Right? One thing you may respond that, hey, these tumor cells should be releasing DNA, right? But you can see that the blue line, the blue versus light blue versus green should be kind of equal, right? There should be 1 to 1 to 1. But instead, you can see there's a skew towards the dark blue. And that suggests there's actually amplification of BRAF. And in fact, without going into details, there was evidence of both amplification of BRAF and MET in this patient as they became resistant to the pure targeted therapy. We didn't believe this because it's the early days of cell-free DNA. So we biopsied one of the progressing lesions and compared it to the biopsy at diagnosis. And compared to diagnosis, you can see again, there was now amplification of BRAF and MET amplification. And these may be mechanisms of acquired resistance to the pure targeted therapy. And so we said, okay, what do we do now? There was data from this Italian group that this is a known mechanism of resistance and that you can actually overcome it by adding on a MET inhibitor, crizotinib. All right? But this patient was actually getting sick, and it will still take us in the US about a month or two to get the drug unapproved for pediatric patient. And so we thought this is an unusual situation in which the patient has not had chemotherapy for about 5 months. And so we said, let's put in second-line chemotherapy while getting the drug. And so we initiated FOLFIRI. And what's interesting is that she had a very nice response again, serologically, and her cell-free DNA also cleared. All right? So she had a very nice response to second-line chemotherapy after this delay. Of course, this didn't last. After about 5 months, we start to see dramatic progression by serum markers. But in the cell-free DNA, something very unexpected happened. You can see that it went away, then as she started to progress, you can see the cell-free DNA starts to come back. But you can see, if you look at just by visually here versus here, you can see here there's a skew of dark blue to light blue to green. But here it's back to 1 to 1 to 1. All right? And in fact, here, there was no longer evidence of either BRAF amplification or MET amplification at that time, at the time of resistance to chemotherapy. All right? This strongly suggests that the cells that were selected for resistance under pure targeted therapy were actually a different clone than the cells that came back under resistance to second-line chemotherapy. All right? So that the resistant clone that came up under FOLFIRI no longer had the molecular features of resistance to targeted therapy. Right? And this is kind of wild because in oncology, we always assume that resistance to therapy is cumulative and irreversible. We go from regimen A to regimen B to regimen C. We never go back to regimen A. All right? And so if this is true, we should be able to re-challenge her with the same inhibitors. All right? And so we did. So actually based again on phase 1 data, we don't make this stuff up. There's phase 1 data in which we could say that we could safely combine vemurafenib and cetuximab, a BRAF inhibitor plus an EGFR antibody, together with irinotecan. And the reason we did this is because some of the liver lesions went away on FOLFIRI. We thought, well, let's keep the irinotecan and just add a BRAF and an EGFR inhibitor. When we did that, she again had a dramatic response. All right? And this really proved that the mechanisms, these pure targeted therapy and pure chemotherapy, are completely non-cross resistant. They're placing different selection pressure on the tumor. All right? And that's kind of the holy grail. We came up with multi-agent chemotherapy thinking that they'd be non-cross resistant. All right? But unfortunately, often resistant one therapy becomes. But this is truly non-cross resistance. All right? And, and again, with the cell-free DNA, again, she had a nadir. It didn't go as deep as before, but it went in. And so without going into details, this is something we published past year or two. We did this a couple of times, alternating therapy and following the dynamics. All right? Ultimately, we treated her for over 2 years. This is, which is better than we think the natural history of advanced BRAF mutant colon cancer is, which is pretty aggressive disease. But we didn't just go chemo 1, chemo 2, and then death. And in many ways, we treated this in the worst possible way because we waited for gross progression before switching treatment. You imagine that if we were clever, we would have switched treatment when the slope of the response changed. All right? And imagine if we had switched treatment instead of waiting up to here, we switched treatment here or here, we would have maybe really driven those clones down or find ways to combine these. Right? The other thing we learned from this individual patient was that we had lots of radiographs on her, so we followed her, and we found that not all metastatic deposits had all evidence of all the resistant clones. Because you often think, once you get resistance, all the metastases are resistant, they're all the same. All right? But intriguingly, we went back and carefully went through all the lesions that she had. There were some lesions in his liver, like L1, that were at diagnosis, went away with FOLFOX, and never came back. There were other lesions, this one L2, which came up under resistance to FOLFOX, went away with targeted therapy, but then came back. Kind of came and went. That had a mixture of all the resistant clones. Even tumors that arose late in her course, this came up on FOLFIRI. When we switched to targeted therapy, it went away and stayed away. So even late metastases aren't mixtures of all clones. And that's really important because that suggests that there may be rational use of ablative therapy at some point, when needed. Maybe we should have ablated this lesion early on, and then, so this is in a patient. So, ultimately though, it's an anecdote. So we got to convert anecdote into science. And this, maybe we helped this patient, maybe we didn't, but we need to certainly help the other patients as they come along. And so we worked with our colleagues. So one of my colleagues, Mike Verzi, had actually developed a mouse model of BRAF mutant colon cancer. Interestingly, if you put BRAF V600E into the LGA54 intestinal stem cells in mice, you don't get cancer. It actually just induces differentiation. And so he said, in order to do this, you have to also knock out SMAD. So if he turns on BRAF V600E and knocks out SMAD, now you get a model of serrated BRAF colon cancer in the mouse that looks a lot like the human. All right? And we said, okay, we got this model, BRAF SMAD, which is what our patient had, and said, hey, can we make organoids, which is nice because we're having a discussion on organoids later. So we made organoids from these mice and said, hey, do they behave like the human patient? So this is work from Kevin Tong, who was a postdoc and now is a faculty member at Hackensack with his own lab. And without going into the details, these organoids showed that these BRAF mutant mouse intestinal cancers were resistant to either EGFR inhibitor or BRAF inhibitor alone, but the combination worked. So just like the humans, it had that same adaptive resistance. All right? So then we said, okay, we know this patient developed resistance by overexpression of MET. So we took these organoids and overexpressed MET. This is the blue ones are the organoids that are MET amplified, and the red are the parental. And you can see that compared to the red, the blue now are resistant to combined therapy with EGFR and MEK inhibitor, just like the patient was. All right? So we can induce resistance to targeted therapy by amplifying MET. But what was important was that same blue tumor that's MET amplified, even though it's resistant to targeted therapy, is actually remains sensitive, in fact, more sensitive to irinotecan. So inducing resistance to targeted therapy by a specific mechanism actually didn't induce resistance to chemotherapy. All right? So now we can model these clones, make mixtures of them, and say, hey, if there's a mixture in present, what's the right combination or regimen that could try and eliminate these up front. All right? And this kind of, we've seen, literally thousands of patients, this kind of thing, even though it was one of our earlier patients, we see this kind of dynamic response and resistance over and over again in the clinic. All right? And it's telling us something that we have to think about how to do this. Again, an early case of an EGFR mutant lung cancer was a patient who had EGFR L858Rs, activated mutation together with p53. This is 2013, so we treated the first generation inhibitor, and she did well for about a year. On progression, we rebiopsied, and you can see now that in addition to her EGFR mutation, there's now amplification, and now also MET amplification. Common theme, right? MET amplification there, MET amplification pops up again here in this lung cancer. And so back in 2013, we actually added on crizotinib to erlotinib, based on preclinical data. And she actually did well for 2 years. All right? But then, on progression, we biopsied her. And now what happened was now she developed T790M, the resistance mutation to the first generation inhibitors. And she lost the MET amplification. This clone does not have MET amplification. And this is a different clone because there's no p53 mutation, and we did high-depth sequencing, so it's not a false negative, and instead has CDKN2A loss. So this is a clone that is separate from this clone and is ancestral to it. All right? So it's actually p53 wild type, but had CDKN2A loss. All right, so 2016, osimertinib came on board. We treated with osimertinib, all right? And she did well for about a year. And then on progression, we biopsied her. What came back? This damn clone. The MET amplified clone came back. All right. And then so we had, she had actually a CNS progression at that time, so we biopsied, radiated her brain, and then actually put her on osimertinib plus crizotinib. And wildly, she did well until 2021 on that combination. And then she progressed purely in the brain. And so there were multiple lesions, so we resected one. And when we resected it, it was the same clone. And you guys know why this is the same clone? Crizotinib doesn't penetrate into the brain. There's no selection pressure. All right? And so there's no drug activity. Tumor stays the same. And in fact, unfortunately, at that point, even in 2021, we were trying to get the third generation CNS penetrant MET inhibitors, but we couldn't get it. We couldn't get it approved by insurance, even in the US. All right? We'd also use this kind of method of following things to identify, novel mechanisms of resistance. Again, I'm going to use lung cancer just because I know we're talking about this later. And so again, this is one of our patients early on that, again, EGFR L858R, was treated with erlotinib and then developed a T790 mutation on progression. She was sent to a clinical trial of ruxolitinib, a novel EGFR inhibitor at that time. And she had no response. And in fact, when it progressed, you saw the same mutation. And this is because this drug ends up not working. In fact, it was dropped. All right, again, no effectivity, no selection pressure. All right, on the drug. Then she was placed on osimertinib in 2016 again. And she actually did well. And then on progression, she had L858R and then a novel mutation, M776Q in the kinase domain, which no one's ever seen before. All right? And so now the question is, okay, we see this new mutation. Is this mediating resistance or is it just noise? And if it is mediating resistance, will it respond to any drugs? Can we figure this out? All right. Well, the cool thing is, nowadays, there are these protein data banks, right? So Rutgers, where I was, actually had the protein data bank. So we can do homology modeling of this mutation. So we just model this is work done by our colleagues at the Precision Data Bank and also Castellino, one of the grad students in the lab. And so we just homology modeled the effect of Q776M on osimertinib binding into the cleft, and it caused steric hindrance. And so this strongly suggested that this was a resistance mutation. And so we took it to the lab and modeled it. Without going into details, we can then model EGFR in cis with L858R, and also when you induce the mutation, instead of the parental, very sensitive to osimertinib, this is now resistant. And in fact, if you model this mutation in cis with in cis with L858R, you are now resistant to osimertinib, erlotinib, afatinib, but interestingly, you are sensitive to neratinib and poziotinib, all right, because it's an exon 20 mutation. And so, by seeing what's going on in the clinic, we'd immediately, model this and figure out, novel resistance mutations and new mechanisms of treatment. And this kind of stuff I'm doing, we can go through this. There's lots of things. I'm not going to go into any of these, but I'm saying that, well, these aren't one-offs. There are lots of patients when we start doing this regularly, we start to see how the tumor actually changes over time, clonal progression, small cell tumor. You can see all these things going on. And if we have the radiographs, we can actually see, the dynamism of, where the clones may be even physically. And this kind of, I think, is, we're just starting to build this. We're starting to see, these are still anecdotes, but now we're starting to now do this on all patients to then start to build clinical trials and models to understand how these tumors evolve under effective treatment. All right? So in summary, we think that rapid clonal dynamics can occur in response to effective target therapy. And this also suggests there's a fitness cost for resistance mutations, right? These resistance mutants were only more fit while, when we saw the loss of this resistance mutation was only more fit during the time when she was getting therapy. Right? This is like what infectious disease figured out, right? Multi-drug resistant, E. coli is actually less fit than the parental drug-sensitive clones, right? They only are more fit when the antibiotics are on board. Similarly, some of these resistant clones are only more fit during our treatment and actually regress, and they'll be taken over by the parental when we take off the treatment. And so we need to find, non-cross-resistant treatments. Serial can be cover actual mechanisms, and we need to really find truly non-cross-resistant treatments. We need to find our 4-drug regimen for TB, or our highly active retroviral therapy. And if we're lucky, cancer will be 10,000 different HIVs. We have to find combinations of non-cross-resistant drugs that really will work. But we have to identify. We're not going to find a treatment for lung cancer. We will find a treatment for ALK mutant lung cancer. All right? I'll buy this way. And with that, I just thought, people also wanted me to talk about what are the needs for molecular oncology program, and what are the things that are here. And I think, the first thing you need is medical and scientific multidisciplinary expertise. And that clearly is present here. You guys clearly have the multidisciplinary expertise. You take both the science and the clinical expertise here is phenomenal. All right? You also need access to genomic and molecular assays, and they have to be affordable and appropriate. All right? And that's something, I think, you have a better idea of what are the needs, what are the assays that are needed in the most prevalent diseases that are here. And we need access to therapeutics, right? Because there's no point in finding these if we don't have access to therapeutics that are affordable and appropriate. And I was speaking to the physicians at Tata Memorial, it's a great talk on head and neck cancer. They're really doing outstanding clinical trials to make appropriate, affordable, and effective treatments for the local population, all right? And I think that's nice. We also, of course, need the infrastructure, basic translational and clinical research, and multidisciplinary collaboration, as well as institutional support to support these kind of things. But I think this is the future of oncology, and I think this is something that you guys are going to be part of developing. It's going to be important to treat the people that are under your care, and I look forward to see what you guys are going to do. All right, thanks so much.
Thank you, Dr. Sridhar, for this insightful talk. And I think you have beautifully illustrated the journey, the clonal journey of a cancer, and how heterogeneous a cancer is, and how tough the job of an oncologist is, that the treating clinician has to be at their toes to see which new mutation has cropped up and now what is the appropriate target therapy. I'll request if anybody has any question from the audience for Dr. Sridhar.
Well, one thing I didn't point here is I think that NGS should be done up front, because I think it's really not a companion diagnostic for treatment, but actually part of the classification. It's amazing when we sequence how, unexpected diagnosis can change. There's a patient had a lump in the breast, biopsy, pathologist says adenocarcinoma. We staged, there's a lump in the lung. Biopsy, oh, that's also ER positive, it's metastatic, breast. We sequence, KRAS G12C, high mutation burden. It's a lung cancer that's metastatic to breast. Changes treatment dramatically, all right? And this is actually more common than you would imagine. Not because pathologists are bad, because they have a really hard job. I mean, they have to literally look at it and tell us what it is, and then we base all our treatment on it. I think this is another feature. Think about heme malignancy. So I did heme malignancy for a long while. Look at flow. Flow is not a companion diagnostic for CD20. CD20, is not a companion diagnostic for rituximab, right? It is part of the classification. Heme pathologists will not be comfortable with the diagnosis of heme malignancy without the flow. And I think similarly, in the future, I think a pathologist will be uncomfortable with the diagnosis of a particular kind of cancer without having the genomics at hand to support the diagnosis. It's already in brain cancers and stuff right now, that is part of this. So I think, two things. I think the genomics is going to be part of the diagnosis and classification, not a companion to tell us what treatment to use. All right? Hopefully that will also do this as well. The genomics answers all sorts of questions. Someone has breast cancer. 10 years later, they're up a lymph node in the neck. You biopsy it. It looks like the breast cancer. Is it the same one? You can tell 100% by sequencing both the primary and the recurrence. They're the same mutations, the same cancer. If it's different, it's a different cancer. And that will completely change management, even if none of the mutations are actionable. All right? Because it tells you something about the natural history of what happened. Right? So I think genomics are part of understanding the biology. I think it's essential for the classification and give us all sorts of information, even if none of the alterations right now we have drugs for. All right? Sure. Sorry.
Circulating DNA can be used in CNS tumors, circulating DNA.
Oh yeah, so this is tough. So CNS, not all compartments of the body release cell-free DNA equally. All right? So the CNS, you can have big tumors and often, or even mets to the brain, and not much cell-free DNA is released. Similarly,
Primary CNS only. Any
well,
primary CNS?
primary CNS, I think it is hard, you know. I think they detect less, and so they have to use very, very, you know, people love to sit there and go, can you pick up, you know, DPG by looking for the histone mutations in blood in pediatrics, right? Because it's such a hard diagnosis to make. You don't want a biopsy, all right? But I think we have to develop much more sensitive assays, because I think there's far less release in some CNS tumors and also peritoneal tumors. You can have a kilogram of disease in the peritoneum, and it doesn't shed much cell-free DNA, because I think this first pass metabolism through the liver. You know, whereas, you know, a lesion in the liver will give you allele frequencies of 20%, you know, in blood.
Thank you.
Okay.
A very nice illustration, sir, for the developing future of oncology when we detect the targets while treatment.
Yeah.
One short question is there, sir, ki every time there is mutation or every time there is a response to treatment we assess as a clinician,
Yeah.
and the disease progression is there or there is a static disease. So every time to detect new mutation, we have to go for biopsy every time. It is an invasive procedure. So every step you are doing re-biopsy to detect the mutation, what we are targeting there.
So actually, this is where, when there is good cell-free DNA, like in that poor girl, she had extensive liver mets. And so when we draw blood from a central line, we're drawing right from the venous efflux to the liver, all right? So we get, you know, allele frequencies of 20%. 20% of her DNA in plasma is mutant with BRAF, you know? So you see, so it's a very dynamic assay there. So we actually followed her completely with serial cell-free DNA analyses. Those are the fish plots, all right? But occasionally, like in that lung cancer patient, there was no cell-free DNA that was accessible. So we re-biopsied. And we've convinced our interventional radiologists and our thoracic surgeons that it is more dangerous to the patient not to know what's going on, all right? That just treating blindly is more dangerous than the procedure, all right? If you think about it, cancer, you know, just start giving, you know, if we did, you know, osimertinib and then go, you know, chemoimmunotherapy, that doesn't work so well most of the time, you know, for the EGFR mutant cancers. And so we convinced them that, hey, this is actually safer for the patient to find out what's going on than what we'll unsafely do without that information. You know?
Anything?
Sure. I mean, it's just for, you mean germline as well as somatic, or? Wait. Yeah. Yeah. So lung cancer is hard because, you know, obviously, you know, you'll get sometimes by EBUS, you'll get a tiny fragment of cells that says it's adenocarcinoma, there's not enough for molecular diagnosis, and sometimes cell-free DNA is negative. So what we do is that we have to understand the operating characteristics of the assays we use, all right? There's so many times, you know, with clinicians I've seen, they'll get a little biopsy, they say it's adenocarcinoma, it's an Asian non-smoker. Then they'll send cell-free DNA, and they say there's no mutations. And I tell my fellows, there's no such thing as a negative NGS. There always has to be a mutation in the spectrum. If it's a negative, it's a false negative, much of the time. You know, you have to use Bayesian statistics, right? The prior probability of a non-smoker having an EGFR mutation is high. If we don't see it and you don't see a KRAS mutation, that means it's quantity non-sufficient. It's not a real negative. You have to get the biopsy then. All right, and I can't tell you the number of times in which that's happened. You know, you have EBUS, a little tiny biopsy. They send cell-free DNA. It's quote unquote negative. They start chemoimmunotherapy. They progress. Sick in the hospital. Now we biopsy them, and there's the EGFR mutation, you know, or the ALK rearrangement, which should have been, you know, diagnosed up front. You know, so I think a lot of there's also education. How to, you know, these tests can be negative, false negative. All right, they're good if they're positive, but there's a lot of false negatives, especially cell-free DNA.
Any other question? Okay, thank you very much, sir, for taking us through this molecular journey of cancer. And if we are as vigilant as you are, I think someday we'll be able to defeat cancer. Thank you very much, sir.
Thank you, sir, for a very insightful presentation. Now, I would like Dr. Deepti Joshi, ma'am, to felicitate sir with a memento as a token of appreciation. Dr. Sir, please come on the stage. Now, I would like to request Dr. Gaurav Dhingra sir to felicitate the chairperson of the session, Dr. Deepti Joshi ma'am, with the memento. Thank you, sir. Thank you, ma'am. Now, I would request all the esteemed guests and faculties to proceed for the high tea. We'll join shortly in 10 to 15 minutes for panel discussions now ahead. Thank you, sir.
Thank you. Thank you for the invite, and I'd like to invite my panelists. Dr. Akansha Chaudhary, Assistant Professor, Medical Oncology, AIIMS Bhopal. Dr. T.P. Sahu sir, Senior Medical Oncologist at Silverline Hospital, Bhopal. Dr. Atul Samaya sir, Surgical Oncologist at Bansal Hospital, Bhopal. Dr. Vinay Kumar sir, Additional Professor, Surgical Oncology, AIIMS Bhopal. Dr. Gaurav Gupta sir, Consultant Radiation Oncology at Bansal Hospital, Bhopal. Dr. Vipin Kharade sir, Associate Professor, AIIMS Bhopal. Dr. Vaishali Walke, Professor and Head, Path and Lab Medicine, AIIMS Bhopal. Dr. Ankur Patel, Associate Professor, Radiodiagnosis, AIIMS Bhopal. Dr. Deepa Singh, Assistant Professor, Nuclear Medicine, AIIMS Bhopal. Dr. Neha Arya, Associate Professor, Translational Medicine, AIIMS Bhopal. And Dr. Prashant Chawre, Professor, Department of Anatomy, AIIMS Bhopal. So, So today's discussion will be on three cases that would highlight precision medicine that we have as of today in 2025. So this has already been talked about by the previous speakers, how the biology of lung cancer in our dictionaries has changed from just a histologic diagnosis to a molecular pathology level. And that has translated into better types of treatments available in the form of targeted therapies, immunotherapies, and has led to a subsequent improvement in survival and responses. So this is the latest change that we have in lung cancer management, that is the TNM9 staging, where there has been a difference or a split between the N2 involvement of N2A and N2B, where N2A is a single station mediastinal lymphadenopathy. And M1C has also been split into M1C1 and M1C2, and this is to take care of the oligometastatic variety of lung cancer. So coming to the first case, so 57-year-old smoker with ECOG PS1 had a history of cough with hemoptysis. The CECT showed a left lung mass with collapse of the left upper lobe, and he had presented to the pulmonologist, and bronchoscopy was done, which revealed a squamous cell carcinoma. What I want to highlight through this case was this was one of my first cases during residency, and over the course of the last 8 years, how management has changed. So 2017, this patient had come to us. Obviously, we will be discussing the management as of 2025. Sir, Dr. T.P. Sahu, sir, how would you further evaluate the patient?
So I expect that I would do two things. One is a PET scan, if it is feasible, or a good quality CT scan with a bone scan. And apart from that, based on it, if there are some mediastinal nodes, then I would preferably go for non-invasive or minimally invasive staging of the mediastinum rather than a mediastinoscopy. I don't think mediastinoscopy would be having any role in the modern future except for select settings. It is a minimally invasive staging of the mediastinum depending upon how the scan pictures come to.
Dr. Akansha, anything further you would like to add?
Actually, I would, because of the present day guidelines, because the patient, because he's a smoker, then so now further EGFR ALK testing is needed. Apart from that, no NGS panel. I don't want to do anything else.
Okay.
And EGFR ALK also, because actually smoker, so here we'll go away with it. So
go over with?
Will not go.
Will not go with it.
Because if it's a non-smoker, then we'll do it off.
Okay.
And staging is there. Apart from that, if it's stage 3, stage 4 brain also, we can image MRI brain.
Yes.
So,
Dr. Vaishali ma'am, anything that you'd like to add to the biopsy in terms of any other IHC or molecular testing?
Hello. So the current guidelines mention that if it is a small biopsy, then there are some recommendations that what you are supposed to write or mention and what you are supposed not to mention. Okay. So morphologically, if we are getting appears to be a small biopsy, in that case, it is recommended that if there are multiple cores, you should split the cores into multiple blocks so that one of the block can be preserved for the routine HNE or any special test, stain mucin, and another block should be preserved for a high-end test like IHC. And even if IHC we are doing, we should not, pertaining to that morphology only, the IHC should be performed 2 or 3 stains, and that other, the same block can be preserved for the molecular characterization.
So which stains do you perform usually?
For when we are getting a non-small cell carcinoma, for that matter, then in that case we go for for squamous or adeno, we TTF, or we go for napsin or P40 or P63. That is recommended, either of the.
So only
any of
two
the
markers,
Two
yeah.
markers, and or if the facility is not available, then mucin stains can be done. So stains in that category, IHC or a histochemical stain, can be done for the definitive where and if there is a like a adenosquamous kind of thing, then those, or in situ, this should be not be commented on the small biopsy. Those kind of diagnosis should be commented on the resection specimen. That is what is recommended.
Yeah, I mean, for a biopsy, if you want to comment on adenosquamous, at least more than 10% of that component should be present. Yes, sir.
Just to add to what Madam told, I just agreeable to all the things except for one thing. Today there are 4 or 5 cores.
Yeah.
I would not split them up. I would prefer them to be in one block, and that will give, when I do a NGS, more chances of getting adequate genetic material for the NGS to be to pass the QC. So the initial thought of dividing them is something we don't practice now. We put it, and preferably would like them to be in a blocks, so that the genetic material for the specialized test is much better. So
Yes,
that's
sir.
the only thing I would like to do.
So in academic institutes where we need some tissue for the repository and for the purpose of accreditation, other things, so we keep one block for the institute and for the documentation purpose, and one of the other block we give it for higher end investigation for
Sure.
outside. That is what is
Sure.
we practice.
So he was staged, as our panelists have rightly said. The role of IHC has been described by ma'am, where only a P40 or a TTF1 is required. I'll come to the molecular a bit later. So extrathoracic modalities, we use a PET scan and a contrast MRI brain for anyone that is T2 or higher. And intrathoracic, as Dr. Sahu rightly pointed out, that we are going for an EBUS or a minimally invasive approach rather than a mediastinoscopy. Dr. Deepa ma'am, if a patient has come, if he's with a history of smoking and on a CT he has a speculated lung mass, would you like to go for a PET scan before a biopsy, or would you prefer that the biopsy occurs and then you go for the staging?
Definitely, PET CT scan before the biopsy. It's helped to guide the biopsy. We can do
Yes.
the PET guided biopsy also. It identifies the loco-regional disease apart from the characterization of the lesion and the metastatic involvement. The PET scan is a one-stop shop.
Yes.
So you can screen whole body in one imaging, and it help you guide further for the treatment planning and the response to therapy. So it's best to do the PET CT.
Yeah, so the point of a biopsy is also to stage the disease. So if a PET scan shows there is a supraclav lymph node, then likely mediastinal staging should not be required. We can just go for a lymph node
Sonak,
biopsy.
I will differ on that. I would like to have the biopsy can be done easily. It is accessible. I would like to have a biopsy first before doing a PET scan.
Sure,
if
sir.
there are problem when our access for the biopsy is difficult, in those cases probably PET will help. If I found some other lesion to suitable lesion for the biopsy, but first step is biopsy, and you get surprises. Many times you get tuberculosis, fungal infection.
Yes.
So PET scan is unnecessary in those cases. So first is biopsy, unless there are challenges to do a biopsy.
I think I second Atul here. You would preferably do a biopsy still on the CT scan guided. And if it is negative on a radiological appearance where you are, and especially when there's a large amount of necrosis in the CT scan, then a PET will guide you to go towards the active area which is lighted up. So to put it across that I'll do a PET and then a biopsy will be too much at this point of time as per evidence. CT guided biopsy, 80% you will get away with it, 20%, and especially in the patient which has a high amount of necrosis on the CT scan, then she's right, I would preferably do a PET, go to hit the lit up area on the PET scan. That will increase the yield of my hit second time. That's how I'll do.
So please.
Even a peripheral or something,
Yes.
so our ultrasound guided biopsy is much helpful because they can see the imaging and the necrosis part, they can make it out.
I do agree with Dr. Atul because biopsy will give you the nature of disease. Suppose if it is some infective disease, PET is not going to help you in your diagnosis.
Yeah, PET will not help.
Suppose biopsy is some type of sarcoma which is low grade, there is no uptake in PET. So biopsy is going to give you the biology of disease and which suggests whether PET should be done or not. Because if biology is like that, it is not going to uptake inside the tumor. Then the PET is not going to help you over CT scan.
Sure.
So definitely I will go with Dr. Atul. What he says is absolutely correct. And we should always do the biopsy first to rule out the infective nature of the disease or some other tumor biology which is not going to take inside the PET.
Yes. Yes, sir.
I would like to add up something. Like some lesions are radiologically indeterminate, so we are not able to classify them as malignant or infective. So in such cases, we either do biopsy or keep them for follow-up. Now, if we are going to do PET, then they will be false positive. It will show uptake because the inflammatory or infective lesions will show uptake on PET if they are in active stage. So it will further add to the confusion. So that's why biopsy before PET is the rational approach for me in most of the cases.
Yes. So that is what our panel settled on. So this is what Dr. Sahu was highlighting, that what are the current best practice recommendations for tissue utilization. That you should have formalin fixation done within a day, and your sections should be 3 to 5 microns, where you use only one section for H&E staining and 2 sections for TTF1 and P40 respectively. The WHO to 2015 has suggested that if on the H&E it is a clear-cut adeno or a squamous, you should be using IHC in a limited manner. So this was the PET scan that we did for this patient. This is back in March 2017. So we can see a left hilar mass with collapsed consolidation, and there was a single ipsilateral mediastinal lymph node of 1.5 by 1.7 centimeters. So Dr. Vinay sir, with regards to surgical assessment for this patient.
Yeah, we have to stage the disease first, and we have to confirm this mediastinal node, whether it is infective or it is malignant disease.
Yes.
And then we have to further categorize in mediastinal staging, because if it is N1, then your approach is different, and then it is N2, then your approach is different. So I would like to confirm this mediastinal node with EBUS or some endoscopic, mediastinoscopic guided biopsy.
Yes, sir. So we had done the EBUS, and the EBUS TBNA was positive for malignancy. So basically this came out to be a single station N2 or N2A as per the TNM9. And Dr. Atul, Dr. Vinay, regarding the operability of this patient.
Yeah, regarding N2 mediastinum, if we operate upfront, then the survival is not good, because the various data suggest that N2 mediastinum upfront surgery limits your survival. When N2 disease stage is confirmed and the staging as well upfront treatment, we have to discuss if we give the neoadjuvant treatment, certain chemotherapy or some other modality of treatment, some immunotherapy, then it is going to enhance the survival. It will downstage the disease and followed by surgery. So if N2 mediastinum is confirmed on biopsy, then we will go for neoadjuvant treatment.
N2 only single station.
Single station.
Single station I will consider for the surgery in future, otherwise not, because the prognostically they are bad. And second thing, if I am planning a surgery in future, I would like to assess the patient whether he is fit enough to go for the surgery in the future or not.
So sir, what test do you perform in regards to that?
One is the clinical assessment, performance status, and PFT. This is generally done. DLCO is not doing, I have not done till now.
So what value of the cutoff that you use for FEV1 or FVC parameters?
Generally FEV1 70 is the cutoff for the major resections. Or if it is a small, because it is an N2 disease, so anyway requires major resection. So if FEV1 up to 60% in a certain selected patient, we can consider for surgery.
Yes, sir. So, sir, then I assume you'd send this patient across to the medical oncologist. So, Dr. Kancha, what would be your any further testing that you require today that we didn't have back in 2017?
Yeah, PDL1 status I would like to.
Yeah, so let's assume the PDL1 to be 30%.
Okay. So, considering the PDL1 status as positive, so we can go with neoadjuvant chemoimmunotherapy, or because the surgeons are not ready to operate, or
no, it's operable. They've said it's operable.
Okay. So, Yeah, or otherwise after surgery we can go with adjuvant or we can go with perioperative chemoimmunotherapy
So, I
approach.
mean, if you
All
had the
three.
option today, what would be your choice?
I think perioperative chemoimmunotherapy is a very recent and very impressive option which is coming up, which has come up nowadays with overall survival benefit as well. So, and PAT-CR responses are also around the tune of 18 to 20%. So it's very impressive. So I'd like to go ahead with
The perioperative. Any particular drug?
Durva or Pembro, anything is okay. Both.
Pembro plus chemo. Sao, sir.
First things first, today this patient should not be operated upfront. That's very clear.
Yes, sir.
Even a T3N1 also should go to a new adjuvant setup.
Yes, sir.
Point number one. Point number two, with the PDL1 more than one, it gives you further scientific evidence that these patients are going to do much better. So it has to be a immune checkpoint inhibitor with a chemotherapy. That's point number two. What can you give? Nivolumab has probably the best data set as of now.
Yes.
Pembro, there is a data set. Durva also has a data set. In the Indian context, I would still not hesitate to go for the new adjuvant intent. But yes, it has to be my drug of choice. But I would mind if he follows AGN and does it. So that's how it should be. It should be immune checkpoint with chemotherapy. Perioperative has the best data set as of now, but Indian scenario finances has a concern. So even 3 cycles to 4 cycles of neoadjuvant Nivo with the chemotherapy would do my job.
Yes, sir. I think the neoadjuvant data is good. The Keynote 671 is the only one that has an OS as of yet, but rest is still to mature. Yeah. But one more aspect that I would like is that these patients need to be EGFR ALK negative as well.
Agreed.
So
if you look at the Pembro data, they had 4% which are EGFR ALK positive, but they did not analyze it. But all said and done, we have enough knowledge to tell us that we will not use immune checkpoint in a targetable mutation.
So what modality would you test EGFR and ALK, considering that you want to initiate treatment as soon as possible, and that NGS, if you take
I don't think so. You are in a hurry to
days.
do it. Why are we in a hurry to do it in 7 days? If it is 14 days, what will happen? Nothing. The tumor is sitting for a few months now. So my point is, I would like to have my lab test here. We are not dealing with a metastatic disease where the performance status is very, very poor and we want to go early. So I would wait for the test to come in, and I will not hesitate to use ALK will be IHC based is good enough.
So that is
IHC based is good enough.
EGFR by PCR.
But I think the point which you want to make, the hurrying point, is not relevant in an operable cancer lung. I'll still wait for my NGS to come in. Let's say you have further targetable mutations. Although the trials, none of us used it, but still I would not be comfortable to use an immune checkpoint in a targetable mutant setting, except for maybe KRAS. Maybe KRAS. So there are issues. So I will probably wait for the NGS to come in, apart from the PDL1, and ALK with IHC has to be confirmed. That's okay.
Yes, sir. So, and again, we were highlighting the multidisciplinary effect that a team has, and this proves the best approach for our patients.
I would like to point out a small thing. Can you go back 2 slides, images? Yeah, so the lesion looks too close to the left pulmonary artery to meet, so it could be very well a T4 lesion.
It could be.
It could be. You have staged it at 3-3, so I think...
Yeah. So these were the approaches highlighted, and Checkmate 816 with the purely neoadjuvant approach has the more takers for it. So back then we gave nab-paclitaxel plus carboplatin day 1, 8, 15 every 28 days for 3 cycles, and this was the response post chemotherapy. The top 3 figures were the initial CT cuts, and the bottom 3 are the post 3 months of therapy. And he showed a good response. There was the atelectasis had resolved, and he underwent surgery, left pneumonectomy with mediastinal lymphadenectomy in June 2017. And fortunately, this turned out to be a pathologic complete response, which was extremely rare. Further, any treatment options would any of you consider once that he's attained PAT-CR?
Such cases, when PAT-CR is there, there is no role as such, only if margins are positive or residual disease is there. In that case, we offer adjuvant, else not.
Yes, sir. So again, we gave him 2 more adjuvant chemotherapies, This was, sir, back in 2017. There was not much data for a pure neoadjuvant approach. He did well till 2020. After that, he had liver and brain metastasis. So,
Just one comment on the surgery. This patient should have been considered for sleeve resection after the very good response rather than going for pneumonectomy because it was a lower lobe mass, and so sleeve resection would have been a better option for him.
yes, sir, agreed. So this is the data from the Checkmate 816, which shows a good event-free survival and the pathologic complete response and the major pathologic responses that we are seeing in patients today. This is the second case, 68-year-old female with a 10-pack year history of smoking, a left lower lobe mass, CT scan shows a 4 centimeter mass with subcarinal adenopathy. PET also confirmed that, MRI brain is negative. The staging workup was done, stage 3 adenocarcinoma, multi-station N2 disease, EGFR ALK negative and PD-L1 30%. The tumor was deemed unresectable at the MDT. So Gaurav sir, how would you like to approach this patient?
See, multi-station mediastinal lymph nodes being positive, it's N2.
Yes, sir.
So surgery is out of question. So I would like to go for radical RTCT followed by further, maybe Durva.
Yes, sir. Yes, sir.
One question to Dr. Gaurav. Why are you planning for radical RTCT? Why don't you want to downstage the disease and further go for resection followed by adjuvant RT?
Sir, my volumes are always the same. If I am able to save lung parenchyma in a good way and able to respect its tolerance, it's better to hit with radical RTCT rather than giving neoadjuvant chemotherapy.
I'll second Gaurav here. The concept of when you're going for radiotherapy and then you give a neoadjuvant, there is no data set to tell you that the NSCT followed by CTRT is best superior to CTRT alone.
Yeah.
So it's standard for surgical patients to go for neoadjuvant chemo and immuno. But for radio chemotherapy for N2 with the subcarinal nodes, if the multidisciplinary team has told, the surgeons have told, no, we won't assess it and take it as operable. I think it's a fair thing to go for concurrent CTRT and go for the radical CTRT.
Definitely. But however, this is also an old case. So he received induction pemetrexed carboplatin for 2 cycles and then concurrent CTRT. Sir, Gaurav sir, any precautions that you would give during radiation for this patient or the dosing adjustments?
We need to, if patient have received chemotherapy earlier, we need to try to reduce the lung dose further because incidence of pneumonitis goes up when you are giving post chemo radiation, and it becomes difficult, and especially with lower round lymph nodes, esophagitis incidence also goes up. So we need to be cautious for esophagus and lung tolerance dose.
So again, if CTRT upfront is possible, we would prefer that rather than going for induction, as Sahu sir also pointed out. And considering that post CTRT, they will be eligible for either if EGFR positive, then osimertinib, or if PD-L1 positive, then durvalumab. Both have incidence of pneumonitis. So Dr. Kancha, Dr. Sahu sir, how would you evaluate the patient after CTRT with the judgment of pneumonitis in mind, and how comfortable are you in using these therapies in the adjuvant?
First thing is that the incidence of pneumonitis post CTRT is around 10%, 5 to 10% in good centers with a good planning.
Yes, sir.
So the point is, and you can wait till 45 days, 42 days, and I think practically you can wait till 2 months.
Yes, sir.
So that is where it is, and the incidence of pneumonitis resolves. It's around 2-3% or 5% who will not be eligible, and that's something I'm okay. And then for those patients who have anything less than grade 2, I would not hesitate to start a durvalumab in this case because EGFR ALK negative, 30% PD-L1 positive. It's a durva for 1 year, and that is where it should be. Pacific is the data set for it.
So do you give durvalumab only for the above 25%?
No, if you look at the above 25%, no. That was the analysis on which they did it, and on the exploratory analysis for less than 25%, they showed that if it is PD-L1 negative, they do not benefit more than 1% benefit. So for me, although Pacific allows us to give for all comers, I would still not use durvalumab for anything who's PD-L1 negative. And if you look at the newer trials by AstraZeneca, they have also shifted their inclusion criteria to only PD-L1 positive. They're running a Pacific 9, which they have a TIGIT inhibitor with durva, and they have made the inclusion criteria to be PD-L1 positive. So point here should be, we should be giving this costly drug to patients who benefit the most. And Pacific really showed us that PD-L1 positive only helps. And it has to be EGFR ALK negative.
Negative. Yes, ma'am.
Hello. So this PDL1, I was just want to add on. So PDL1, because different clones have given different range of positivity. So it is, if it is a DACO, it has given 1%, but it is a Roche, they have given 10% positivity. So you consider this as a parameter or?
Madam, the 10% positive, it is actually as per the site specific and the antigen which you use. And the CPS score, when we use with 22C3, which is mainly the use for pembrolizumab, that is where the CPS score comes into. There are some data sets, like let's say gastric cancer, or let's say breast cancer, triple negative. The CPS score more than 10 actually is the benefits where we give for metastatic. So in here, it is PDL1.
So it is tumor proportion score you are calculating rather than all the cells in the...
With regards to Pacific, with regards to the lung cancer, which I am doing here.
So
but if you look, let's say we have a metastatic disease and you want to use pembro, we can use CPS score. So it is actually as per trial and the site specific. It is now changing and we have to be very careful what we are using actually.
Okay.
But as far as the multiple clones analysis are concerned, even SP142 and SP263, they show a good concordance.
The concordance, there was a trial which is quoting to all showed to be concordant. 142 was little lower than the 28.8 and the 22C3. So they are concordant, except for SP142, which is little lower.
Okay, thank you.
So the last case, so this was an elderly 82-year-old PS1, comorbid hypertension and dyslipidemia. Past medical history, he had a CA prostate back in 2005, had undergone a radical prostatectomy and lymph node dissection, did not require any adjuvant therapy. He also had a total thyroidectomy for multinodal goiter in 2018, where there was a single foci of papillary carcinoma. His brother has a history of CA prostate. His current illness, he presented to us in July 23 with he presented to us in October 23 with a 3-4 month history of dry cough, and there was weight loss of 4 kgs, and the HRCT showed a right lung mass. So further evaluation, Dr. Akanksha?
I would like to first evaluate what is in the form of imaging, CECT or PET-CT. So once we have that,
yeah,
and
so
biopsy
I'll show you the, so this was the PET. So the PET shows a right lung lesion. There is peribronchial lymph nodes, mediastinal lymph nodes, multiple pleural nodules, liver metastasis, adrenal lesion, bony mets, and MRI brain also showed one.
Biopsy of the lesion, whichever is feasible.
Yeah, I guess liver.
And yeah, this has been previously. I would like to do PETs first. So, anyways, now that we have biopsy, so I'll like to send for NGS panel along with the PDL1.
So NGS, would you want a limited panel or a comprehensive genomic panel?
Comprehensive genomic panel is recommended. So, if the finances permit, I would like to go with that.
Okay. Dr. Sahu, sir, any?
I think any given day finances permits, I'll go for a comprehensive. But at least if that is not, I'll at least go for the 12 where we have a target drug which is targetable. So comprehensive should be the go-to, but at least the minimum is 12. The procedure and the quality checks should be important that they do not run a hotspot NGS. The point is, if they run a hotspot NGS, then we are going to miss out on a lot of mutations. It should be a more broader, where we are like exon 20. It's a 99 or 100 types of mutations that are possible exon 20. If you run a hotspot, you are just going to hit on that spots, and then you will miss a lot of mutations. So that's my point. I think, you want to add something?
I agree. I think, when you can and when it's feasible, the larger panel in this setting would be best.
Ma'am, from the translational medicine point of view, what differences do you have in doing a hotspot panel versus a comprehensive genomic panel?
So as Sir just mentioned, I mean, if we do a comprehensive panel, definitely we'll not miss out to, some mutations which don't appear in hotspot. But, and of course, the costs involved are quite, challenging. So we really have to look at that aspect. And maybe, if one could also look at developing some patient-derived organoids, and we could do some, testing on those organoids first, and then also give the right drug regimen to the clinician, so that they, apart from the NGS panel, they could also look at the treatment profiles which we receive from patient-derived organoids.
But then
So
how
that
long
could,
does it take to develop these organoids and then test the drugs on them? Because the patient is sitting in front of us that they need to start the treatment.
Right. So I mean, at least few weeks it will take to give the entire data to the clinician. So I mean, it depends if they could wait.
Sorry. I'm okay with the first part. I'm not okay with the second part. Till it is randomized way, proven, and then I would not let the research come into the clinics. It has to remain in the labs.
Yes.
Till they run a randomized trial to tell me that what we are giving is inferior to what happens in the lab, and when they test in vitro, in vivo, that concept will change because so I would not go the second part. Second part can be a part of research setting. Cannot go to the clinics as of now.
Yes, sir. Not as of now. I totally agree.
So
but
that's
I
important.
mean, I'm talking about if at all.
Why I'm putting it across, because we
Yeah.
are getting reports from patients who are coming with the drug sensitivity, chemosensitivity reports. This is the drug we want, and these drugs are not approved for that organ itself. So I think there are issues, and I think we should be waiting for further trials to come in. So that is point number one. That's what which we wanted to highlight.
So this
And number two, if I can, when we read NGS report, I have burnt my fingers quite a bit. We only read at the red and the blue thing that is there. The green thing is nothing is there, red mein hai. I think we should go beyond, read the number of reads, the depth of the NGS, the QCs, what has been run, and that will make you a difference in what sir told. You won't miss out if there's a bad lab, depths are not adequate, the reads are not adequate, then you are unlikely to get a good report.
Yes, sir. So this was the IHC. He was TTF1 positive. Single brain met, but he was asymptomatic for that. And this was the comprehensive panel. So EGFR, exon 19, leucine L47, alanine L50 deletion, and a P10 point mutation as well. TPS was 25 to 30%. TMB was 15 mutations per MB. Sahu sir, what would be your further treatment option?
As the patient is EGFR positive and has got brain mets, so best would be osimertinib. The caveat here, because the patient is PD-L1 positive, so the response that we expect in a PD-L1 negative patient may not be there.
I think
so.
That shouldn't make a difference.
No, but
So
there have been
the
trials.
PD-L1 is irrelevant.
Proven, but,
The only thing people err is they go towards the CPS and see that's a 30% immunotherapy they dete. That should not happen. So I think it does not matter. And if you look at EGFR mutations, 50% have high PD-L1 actually. So it's coexistent. So I don't think it matters in the drug of choice.
Sometimes there have been studies where they say we can add VEGF, anti-VEGF bevacizumab to this, because
there is VEGF plus TKI, you have erlotinib plus ramucirumab.
That is later lines of relay trial, but
No, that's first line.
Front line.
Of the relay trial. He's talking about relay
Erlotinib
trial.
plus bevacizumab. So
But it has not shown to be having OS advantage. All the BEV plus TKI have shown PFS advantage, no OS advantage.
But now with TKI alone, if osimertinib, would you consider for radiation to the brain as well? Or if you use a first generation TKI, even in the absence of symptoms, would you consider for brain radiation?
It's very clear. Technically, it's an easy answer, no, because asymptomatic. But if I'm using a gefitinib, I will go for a radiotherapy because the penetration in the brain is very bad. Or I keep a very close follow-up, take a very good consent. If it's osimertinib, I'll be confident. It's a high brain penetration. So I'll be confident to just treat the patient if it is asymptomatic with osimertinib. I can do that.
And who would be the patients that you add chemo to osimertinib?
Yeah, so two things. I will add chemotherapy as per FLORA-2 to osimertinib if there's high tumor burden. That's point number one, which I really want to have a very early, quick response rates. And apart from that, I don't find anything where I need to add chemotherapy as of now, or brain mets patient. If there is a brain met patient, they typically do very poor. I would love to add chemotherapy to osimertinib here. There are two subsets.
Yes, sir.
Here there's a single lesion.
Single brain, but systemic burden is...
Yeah, so you can go for both of them.
Yes.
Either.
So that's what we did, and the importance of genetic profiling has been there.
One small comment is that this is an interesting deletion, right? Because it's a deletion, it's a complex
Yes,
deletion
it's a
insertion.
complex mutation.
All right, and so the insertion Ps are actually a little less responsive.
Yes.
And there's actually a role potentially for afatinib in this setting. But just
So we did give him osimertinib plus pemetrexed carboplatin, and this is what Dr. Sahu was talking about. Flora 2 has given the highest PFS in combination, 25.5 months median. And again, Flora 2 versus Mariposa, even in the intracranial subset, Flora 2 responds better than Mariposa. So, so we started him on pemetrexed, carboplatin, and osimertinib in October, and this was his first PET scan in February 2024. So after that, he's been on, and currently till date, he's on osimertinib plus pemetrexed maintenance, and he's doing well. Take-home message, precision medicine, it has been said in the previous talks that it involves a precise diagnosis, a precise staging, and that only leads to a precise management. MDT improves the outcomes, and focusing on prolonging life along with an acceptable quality of life is what our motto is today. This year's World Cancer Day motto is United by Unique, and in the words of Margaret Mead, always remember that you are absolutely unique, just like everyone else. Thank you.
Thank you, sir. It was a wonderful discussion. I would like to request Dr. Shaunak, sir, just to stay on the stage for a minute. I would request you to felicitate our entire panelists with the memento as a token of appreciation and for a very well discussion. I would request all the panelists to come up on the stage. From medical oncology, Dr. Akansha Chaudhary ma'am, Dr. T.P. Sahu sir. From surgical oncology, Dr. Vinay Kumar sir, Dr. Atul Samaya sir, Dr. Gaurav Gupta sir from radiation oncology, Dr. Vipin Kharade sir, Dr. Vaishali Valke ma'am from pathology, Dr. Ankur Patel sir, Dr. Deepa Singh ma'am from nuclear medicine, Dr. Neha Arya ma'am from translational medicine. I would request ma'am to come on the stage. Ankur sir, please come on the stage. Now I would like to request our own Dr. Radha ma'am to facilitate the moderator of the session, Dr. Shaunak Valame sir. Thank you everyone for this wonderful discussion. Now moving ahead, we will be starting the second panel discussion, and second panel discussion will be on the topic of precision medicine in colorectal cancer. And for this, I would like to invite Dr. Ankit Jain sir from the Department of Surgical Oncology, AIIMS Bhopal, to be the moderator for this panel discussion. Please welcome sir. Dr. Ankit Jain, sir, he is currently being designated as Assistant Professor in Surgical Oncology Department of AIIMS Bhopal. And
good evening. Good afternoon. I would like to invite the panelists for this discussion. I would like to invite Dr. Shaunak Valme, who is consultant medical oncology in Jawaharlal Nehru Cancer Hospital. I would like to invite Dr. T.P. Sahu sir, who is senior medical oncologist in Silverline Hospital, Bhopal. Dr. Atul Somaiya sir, senior surgical oncologist and head oncology services in Bansal Hospital, Bhopal. Dr. Rahul Kumar, consultant surgical oncology at Apollo Siege and Siddhanta Red Cross Hospital, Bhopal. Sir Dr. Hamid Uzaffar Gori sir, who is professor and head of Department of Radiation Oncology at GMC Bhopal. Dr. Manish Gupta sir, who is professor, Department of Radiation Oncology in AIIMS Bhopal. Dr. Deepti Joshi ma'am, who is professor in Department of Pathology and Lab Medicine at AIIMS Bhopal. Dr. Radha Gupta ma'am, additional professor, Department of Radiology at AIIMS Bhopal. And Dr. Suruchi Jain ma'am, additional professor, Department of Nuclear Medicine. Dr. Murli M sir, additional professor, Translational Medicine in AIIMS Bhopal. And Dr. Jitendra Singh sir, associate professor, Translational Medicine, AIIMS Bhopal. So, So good morning. I'm here. I'm a surgical oncologist, so mostly it's I have prepared these slides from a surgical perspective as well as from a little bit of precision standpoint. So basically, this is one of the cases that we had operated. We had come across recently, and we have operated here at AIIMS Bhopal. And so beginning with this. So a 54-year-old male who was resident of Varanasi, UP, had presented with complaints of passage of blood and mucus in stool, decreased appetite and weight loss, intermittent constipation. He is a known case of type 2 diabetes mellitus with no other comorbidities. There is no history of substance abuse, no family history, nothing. So he had done an ultrasound whole abdomen outside, and the patient was provisionally diagnosed with ascending colon and hepatic flexure mass with hepatic infiltration. So I would like to ask my panelists over here that how would you propose the diagnostic workup for this patient? Atul Somaiya sir, could you please?
The colonoscopy finding I am not seeing here. So first step will be the colonoscopy.
Yes, sir.
Once that is confirmed, then we have to do a CT scan chest and the abdomen.
Yes, sir.
This is the basic, and CEA.
Yes, sir.
And then one biopsy is confirmed for adenocarcinoma, the MSI. So,
Okay,
and routine blood investigations like CVC, LFT, KFT.
So, sir, in colonoscopy, would you like to see for other polyps and a complete colonoscopy, or to look for other synchronous lesions or polyps in the colon, or any other lesion in the? Would you like to see for that?
Basically complete colonoscopy. If it is an obstructive lesion we could not do, then after the surgery 6 months later we have to complete the colonoscopy to rule out any synchronous lesion which are present there, because that will change my management also.
Okay, sir. So, sir, if a patient like this who comes with multiple synchronous polyps, so sir, how would you approach for that patient? What would you suggest for doing the colonoscopy of that patient?
If it is multiple synchronous polyps, so I have to see the extent from the rectum to the whole colon, or it is limited to a small. So we have to rule out what is the age? 54.
54 years.
So we have to rule out basically the HNPCC syndrome.
Yeah.
So that is why MSI.
Okay. Is there, I would like to ask that whether there is any role of any genetic counseling at this point of time in the very beginning?
Until unless we have a confirmation of the diagnosis, we should not go for the genetic counseling. Once we have a confirmation of diagnosis, this is HNPCC. And we have to take a detailed family history also.
Yes, sir.
So it is part of history. So if there is no family history, we have to counsel the patient. That it may be the sporadic case also. And based on that, we have to counsel the other family member. There may be some other family member which require colonoscopy.
Yes, sir.
So if there is no family history, the patient has to be counseled, and the immediate family members have to undergo colonoscopy.
Okay. And I would like to ask from medical oncologist, any other additional biomarker or any would you like to know at this point of time?
So, sir has said CEA, and after the biopsy, yeah, I would like an MSI or an
MSI,
MMR.
Apart from MSI.
So, I usually do an MMR because the tests are done by IHC quicker TAT, little bit cost benefit for the patient. It's cheaper compared to MSI.
Any RAS mutation testing at this point of
Not
time?
yet. I mean, if it's a non-metastatic disease, then not yet.
Okay. So I would here. So we did a colonoscopy. There was a circumferential ulcer growth in the ascending colon. The scope was not negotiable. No polyps or synchronous lesions in the rest of the visualized colon. The biopsy was suggestive polydifferential adenocarcinoma. Unfortunately, we did not get the report of microcystic MSI testing at this point of time. CCT was suggestive of growth in the ascending colon and hepatic flexure with contiguous infiltration into segment 6 of liver. And serum CA was very high. It was 243 nanogram per ml at that point of time. So a whole body PET CT was performed, which did not show any other metastatic deposits at this point. Yeah, exactly. Yeah, I agree.
It is not a part of routine staging until this patient is a metastatic
Yeah,
disease.
agree. I agree. This was done prior to us, the patient presenting to us. So I just added on to for the benefit.
One thing is very clear.
Yes,
The
sir.
CA is too high for me not to do a PET scan. 1243 CA is very indicative that 80 out of 100 it will be a metastatic disease. If you remember 80 different ball game,
Yes, sir.
1243 you have a disease which is beyond. So I would be very confident before I think of taking a surgical opinion to do a PET scan at least with the value of CA which you have mentioned.
Yes, sir. Actually, CA, as Sir rightly pointed out, CA itself is a poor prognostic factor. Very high CA levels, they are by itself, it indicates the high tumor burden as well as it promotes the metastatic.
Agreed. So it is basically a surrogate marker of the load of the disease.
Yes,
so 1243 is extremely high.
Extremely high.
So, and that is 80 or 90 out of 100, you will find a metastatic disease with this.
And I also, you were planning to, you are thinking it is, yes, surgically resectable. So nowadays with the availability of PET, of course it is not included in guidelines in initial staging, but at least when you are planning for this invasive kind of tumor which is infiltrating the liver and all, so, and few small pericolic lymph nodes were there on CT also. So it is good if we can do it. And not so controversial also in this case. Na?
So coming to the CECT images, this was the imaging. There was a significant pericolonic infiltration, fatty infiltration as shown in this. Then these are the coronal and the sagittal images showing the concurrent hepatic infiltration. So I would like to ask Rahul sir that whether would you like to approach this case as an upfront surgery or would you like to go for a neoadjuvant?
Again,
setting?
we have enough evidence now, especially such a locally advanced case. I would go for neoadjuvant chemotherapy first.
Yes, sir.
And then post chemo, we'll see the response.
So considering that this patient is a microsatellite stable, then what would the chemotherapy regimen if it is a microsatellite unstable? What would the chemotherapy regimen for this patient? Would you modify your neoadjuvant chemotherapy or neoadjuvant treatment for this? TP Sahu sir.
अरे कीमो का क्वेश्चन उसको क्यों पूछ रहे हो?
नहीं, sir, I was just going to shift it to you.
मैं मजाक कर रहा हूँ यार.
So if it is MSS, then there is a neoadjuvant FOLFOX 6 weeks recommended. But if it's MSI high, then you have the niche 2, Nivo for 2 cycles and 1 cycle of ipilimumab.
So this means that we require a pre.
The only difference is, I agree with him, but if it is a stable, and I don't intend to give immune checkpoint as you told, so I would, at this point, and my surgeon feels that they are not going to operate, it's a neoadjuvant setting, I will look for a rash and BRAF here. So this is where I will then start getting the rash and BRAF, and if it is wild type both, I would love to go for and give cetuximab based therapy with chemotherapy in MSI stable.
Yes, sir. So, sir, any modifications in obviously in patients who are not financially capable? Then in that case, we have got only one option.
Then chemotherapy. There's only chemotherapy. The only point is surgeons are there. They will tell that we will be very careful with the toxicity of oxaliplatin on the liver. Especially, they are going to resect some amount of liver at some point. So,
yes, sir.
yeah, so all said and done, we would be okay. Second point, in such a condition where going for a neoadjuvant, where in a potentially liver resectable, I would love to let my surgeon see the patient every cycle or at least once in 2 cycles. because that is a very important thing, and we would like to operate at the first point when they tell it's operable.
So the patient was, as the patient was financially poor, so he was received 4 cycles of Alfox 6 after we planned for surgery after 3 weeks of NACT. So, sir, I would like to ask Atul sir, what would be the extent of surgery for this patient in this case?
Basically, restaging first, I would like to have a repeat CT scan
Yes,
to
sir.
assess what is the response and the CEA level, what is the current CEA level. So
if
after that, depending on the response, my plan will be there, right? Radical hemicolectomy with resection, non-anatomical resection of the liver.
So, sir, if the disease is stable, not responding to chemotherapy, would you like to go for a PET CT in this condition or now or not?
If CEA is rising, definitely I would like to have a PET CT then.
Okay.
If CEA is, if radiologically it is stable, but CEA has come down, it means it has responded. So I would not like to have a PET CT in those cases. But if CEA is rising, radiologically it is stable disease, definitely will go for the PET scan before going for surgery.
Okay. So, you will, apart from, so we went for the surgery in this. We went for a right extended hemicolectomy for this patient with a non-atomic liver resection with D3 lymph node dissection. And these are the specimens. In the final histopathology, it was a case of moderate adenocarcinoma, hepatic fracture with a serosal breach, contiguous infiltration into liver. The distance from the we performed a non-anatomic liver resection, and the distance was 1 centimeter from the disease. LVSI PNI was absent, and treatment effect, that is the post-NACT, the response was absent, and the margins were free. 1 out of 33 lymph nodes were positive. So the patient was staged as pathological T4B N1A. Now we did a microsatellite instability testing, and it was the loss of nuclear expression of MLH1 and PMS2. While there was in the sir, ये तो हमारे पास बाद में आया patient. So we just received, and it was MSH2 intact, MSH6 expression was intact. So my point is that any additional workup at this point you would require from.
So see, the MLH1 is lost. It could still be due to post-translational modification. So I'd like to do MLH1 promoter hypermethylation. If the hypermethylation is negative, then your chances of a hereditary Lynch is higher. But if it is hypermethylation positive, then it becomes sporadic. Okay. So I'd BRAF, yeah, BRAF and promoter hypermethylation.
Any, would this change your adjuvant treatment plan in this patient?
No.
Same.
Same.
The point is, when it's in such a case, 5FU is not a very effective drug. All of us know, but would I change for a patient who has already responded and he totally responded?
No responded.
The CA is rising?
No, CA is stable. Pathological, there's no response. CA is stable. That's why I asked that it's a stable disease.
So my point is, a Lynch counseling should go on. That's agreed to all of us, I think. The Lynch syndrome is to be excluded in such a patient. Apart from that, for the treatment point of view, I will still go ahead and complete my adjuvant chemotherapy for whatever it's worth. I would not, because there is no other alternative for us in colon cancer actually. I cannot give a single agent irinotecan. I cannot give a single agent oxaliplatin. It has to be with a 5FU base.
At this point, Sir Muli sir, would you like to comment on any pharmacogenomic aspect of this, of the treatment?
I think for the pharmacogenomics, we have to screen for the drug-induced any toxicity screening, and if, say for example for 5-fluorouracil, and this is like a DP,
DPD.
wide variance is more system. Before giving the 5-fluorouracil, if there is any deficiency of these enzymes, we have to stop giving the drug, and there is that will cause the life-threatening as well as the toxicity of a 5-fluorouracils. And if there is any deficiency, as well as there is any a defective in this genes, we have to screen before prior administrations of these drugs.
Just a point to sir has told, is put a very pertinent point. The DPD the thing is we are looking into. The problem is, in the Indian scenario, we have found it to be the homozygous thing, the loss is there, and still the patient tolerate 5FU very well. So are we targeting the right genes is something we're looking into, but what he told makes sense, that if there's a deficiency, then you are very clear that patient is very likely to have high 5FU toxicity and you should not give it. Are we adopting it? Yes, I've started to adopt it, but the point is, the Indian data has been very haywire. So we have to find the right genes in the Indian scenario for this mutation to work. Then we can really predict who is going to have toxicity, who is not going to have toxicity. So you are perfect.
Yeah, even we can screen for any pharmacokinetics variability also. That's also important point, like for like predicting that any like
I think
dose
the
responses
only
also,
thing
like,
that is relevant is what you spoke. The
yes,
DPT.
yeah. Thank you.
Thank you, sir. Thank you. This would end my panel discussion for this. Thank you so much for the. Thank you.
Thank you, sir. I would like to ask you to stay for a while. I would like Dr. Ankit, sir, the moderator of the session, to felicitate the panelists with the mementos. And for the mementos, all the panelists to come on the stage one by one. Dr. Shaunak Valame, sir, consultant medical oncology. Dr. T.P. Sahu, sir. Dr. T.P. Sahu, sir, for one photo, sir. Dr. Atul Samaya, sir. Dr. Rahul Agrawal, sir. Dr. Hamid Zafar Gauri, sir, Professor and Head, Department of Radiation Oncology. I would like the audience to clap for this. Dr. Manish Gupta, sir, he is not here with us. I would like to ask Dr. Priyanka Kanel, ma'am, to take the memento on behalf of Dr. Manish Gupta, sir. From Department of Pathology, Dr. Deepti Joshi, ma'am, our next panelist. Dr. Radha Gupta, ma'am. Coming up, Dr. Suruchi Jain, ma'am. Dr. Murli M, sir. And Dr. Jitendra, sir. And now, at last, I would like to ask Dr. Vipin Kharade, sir, to felicitate the moderator of the session, Dr. Ankit Jain, sir.
Thank you, sir. Cancer therapy has come a long way with groundbreaking advancements in surgery, chemotherapy, radiotherapy, and targeted therapy. Yet one of the greatest challenges remains, that is treatment resistance. With this in mind, it is my privilege to invite Dr. Balakrishna Sir, Professor and Head, Department of Pharmacology and Dean Students Welfare, as chairperson for our second plenary session of the day on the topic, Overcoming Cancer Therapy Resistance.
Dr. Balakrishnan, sir. due to some health issues, Dr. Bala sir is not here with us. So to chair this session, I request Dr. Ankit Jain sir to be the chairperson of the session and welcome the speaker of the session. Dr. Ankit Jain, he is assistant professor at surgical oncology department of AIIMS Bhopal, and he's been awarded as a nodal officer for initiation of MCH surgical oncology program, and he has a varied interest of areas of interest such as artificial intelligence, genitourinary oncology, bone and soft tissue sarcomas, thoracic and mediastinal oncology. I would like to request Dr. Ankit sir to come up on the stage.
I would like to invite Dr. Vivek Ragnekar sir on the stage. Sir is a professor and Professor Alfred Cohen Chair in Oncology Research, Associate Director, Markey Cancer Center, Founding Chair, Global Cancer Consortium, University of Kentucky, Lexington, Kentucky, USA. Sir has over 30 years of research experience in cancer cell biology, molecular biology, radiation biology, drug discovery, development, and moving compounds to clinical trials. Sir, his research laboratory is the first one to discover the PAR4 tumor suppressor gene in 1993 and advanced PAR4 research from the bench to clinical trials. I would like to hand over the mic to the sir for his kind and enlightening words. Thank you, sir.
Good afternoon. I'd like to begin by first thanking the organizing committee for the invitation to be here today. It's really been a great day of talks, also the case presentations, really very informative, and I got to learn quite a bit from this. So my group is interested in understanding therapy resistance in cancer and then designing mechanisms to overcome that resistance. So we look at strategies that work versus don't work and see how to go about it in terms of finding new molecules that could be useful for the treatment of cancer. But that's obviously for the future. As you've heard, if the treatment is not approved at this point in the clinic, it's not going to be useful to the patient. So it's going to take some time, but we still need that, a pool of molecules that need to be present at that time, because as you know, sooner or later, these tumors become resistant to treatment. So basically what happens is, when the tumor is treated, you have a sensitive population that tends to be eliminated, and then you have a resistant population. This resistant population is going to be either having resistance because of something that is pre-existing, maybe intrinsic, or acquired subsequently. Now, this could be, like I said, either internal, intracellular, or extracellular, extrinsic. And there are quite a few factors. I won't be going into the mechanisms, but this slide really depicts the vast range of mechanisms that are out there for resistance to treatment. And this talk will be divided into two parts. One is the observation that we have in the lab, which looks at the crosstalk between the cancer cells which are sensitive to treatment and those that are resistant to treatment. Now, as you know, if you look at literature, most of literature is full of these mechanisms which originate in the cells which are resistant to treatment, and then how they have an influence on the sensitive cells. Now, on the other hand, we've asked the question, is there anything that is produced by the sensitive cells which could potentially influence the resistant cells? And the reason for that was we were looking for mechanisms that are already built in naturally present there, which could be utilized subsequently to target the resistant population. So that's going to be the first part of my talk, the crosstalk between the sensitive and the resistant cancer cells. And the second part of my talk will be on a new molecule that we've identified, which basically targets a broad range of cancer cells, heterogeneous populations, including those that are resistant to the current treatments that are out there in the clinic. So I'll start with this one. And basically, what you know is that, tumors are heterogeneous. And you have tumor cells within the tumor which are sensitive to treatment and those that are not sensitive to treatment. And the general feeling is that when you eliminate the sensitive population, the resistant population will now outgrow. So to address this question, one of the things we did is we mixed the sensitive and the resistant cells. Now, as expected, the sensitive cells were sensitive to treatment, and the resistant cells were resistant to treatment. We are looking at apoptosis as a mechanism of cell death. And these are paclitaxel resistant cells, and they are also resistant to a broader range of taxanes. But what we found is that when we mixed them and then treated them with paclitaxel, not only did the sensitive cells undergo apoptosis as expected, the resistant cells also started responding. So now this is obviously, we are mixing the cells. They are in contact with each other. And so the possibility is that something is being exchanged by the sensitive cells that goes to the resistant cells and makes them sensitive. This is true not only in cell culture, but also in animal models. This work is actually published in Cancer Research a few years ago. And we found the exact same thing, that the tumors which are made, so these are basically going to be xenografts because these are human cancer cells which are either sensitive or resistant. And we chose in this particular model a lung cancer to look at xenografts. And as expected, the sensitive tumors would be sensitive, the resistant ones would be resistant when they are grown separately. But if you mix them, if you mix the cells, you now start finding that the resistant population also becomes sensitive. Now, the hypothesis at this point was then that there must be something either that is secreted or that is something that is being transferred directly from one cell to the other. And I'll tell you the long and short of this is that we found that there were factors that were secreted because when the conditioned medium from the sensitive cells that were treated with that drug was then applied to either the resistant population or to the normal or immortal cell population, we found that the normal or immortal cell population was not affected, but the resistant cell population underwent apoptosis, and this was caspase-dependent apoptosis. Now, basically, you're going to have the question, well, if this is true, that the sensitive cells are releasing a factor, and that's killing the resistant cells, why do we even have resistance? And the obvious answer to that is that the resistant cells are spatially or temporally shielded from that, whatever that factor is, which is secreted. So, knowing all this ahead of time, the idea really was to find out what that factor is. Now, when you think about factors that could be released by a sensitive cell, and that factor could be, targeting resistant population, again, it's going to produce apoptosis selectively. It will produce apoptosis only in the cancer cells, but not in the normal cells. There are very few secreted factors like that that are out there in literature. And so we got an antibody for each one of them, as many as we could. And what we found is that the antibody for the PAR4 tumor suppressor protein was the one that worked the best. MASPIN antibody also worked. The other antibodies did not. So the PAR4 antibody was effective in suppressing this, the activity which was released in the conditioned medium when the sensitive cells were treated with the drug. And so now this activity was not available to kill the resistant population. So this activity, like I said, was neutralized by the PAR4 antibody, which meant that it could very well be PAR4. Now, what was known was, when we found this, was that PAR4, which is a 340 amino acid protein, this tends to get cleaved at this residue here, which is right around 131, by trail. Now, trail is it's a protein which can basically kill. It's an anti-cancer protein which can kill only the cancer cells but not the normal cells. And the interesting thing that we found here was that trail can actually release a 15 amino acid fragment from PAR4. So that 15 amino acid fragment we found through our studies in the lab corresponds to this 1 to 131 amino acid. So basically, what we realized then is that it was quite possible that the cleavage site was in PAR4, and that this factor could be PAR4, either full-length PAR4, or the cleaved fragment, either the N-terminal part or the C-terminal part of PAR4. And so we did the next experiment where we treated the cells, these paclitaxel-resistant lung cancer cells, and took the conditioned medium and asked whether we could neutralize the activity with either the N-terminal PAR4 antibody or the C-terminal PAR4 antibody. And what we found is that the N-terminal PAR4 antibody was the one that succeeded in neutralizing this activity that was released. So that basically meant that this was this 1 to 131 amino acid fragment which was responsible for this. Now, this was not just applicable to the taxane-resistant cells. This was applicable to prostate cancer cells that were resistant to trail. So if you treated the PC3 cells, which are basically sensitive to trail, you could get this 15 kD fragment. You could then use the conditioned medium to ask whether the DU145 cells, which are trail resistant, could be targeted. And the answer was yes, we got apoptosis with the conditioned medium, and that was neutralized with the N-terminal antibody of PAR4, but not the C-terminal antibody. Also, in the prostate cancer cells, which are androgen positive, androgen receptor positive, they respond to bicalutamide. Again, we found that there was cleavage of the fragment, and then the conditioned medium applied to the DU145 cells, which are androgen receptor negative. They undergo apoptosis, and that activity is neutralized by the N-terminal antibody. Also, in the melanoma cells, these are melanoma 16, 17 cells, which are supposed to be sensitive to the BRAF inhibitor. And so now, if we treat those cells with the BRAF inhibitor, this is PLX4720, we find that there is cleavage of PAR4, and the conditioned medium can be applied to the BRAF inhibitor resistant population, and you find that there is apoptosis, and this is again neutralized primarily by the N-terminal antibody. So this meant that the activity was present in cells that were treated with a broad range of agents that could kill the cells, and now that activity could target resistant population. So again, with the trail, we found that the de novo protein synthesis was not really required because we were not able to inhibit that activity using cyclohexamide, which is an inhibitor of de novo protein synthesis. So that told us that new gene expression events were not needed, which is consistent with the idea that in the case of caspase activation, you really don't need de novo gene expression for the activation of caspases. And again, through other molecular studies, we found that this domain, the N-terminal part of PAR4, which we are calling the PAF domain, this is sufficient to cause this effect, which is the factor that's released by the sensitive cells killing the resistant cells in the cancer population. Now, knowing this, we also tested normal cells we overexpressed either a vector or PAR4 or the PAF domain in normal cells. These were mouse embryonic fibroblasts, and then took the conditioned medium, applied that to the cancer cells, and found that again the cancer cells only were eliminated with this through apoptosis. And one point to note here is that cells which are resistant to PAR4 were also killed by this PAF domain, but the normal or immortal cells were not eliminated, were not affected. Again, this is a slightly broader range where we've made a recombinant PAR4 or recombinant PAF, and this is made in bacteria, and when applied to the cancer cells, it will kill the cancer cells through apoptosis, but the normal cells are not affected. We made his PAF, applied that to the cancer cells, and what we noticed here is that it actually does enter the cancer cells. This is an important point because now we could go one step deeper into trying to understand what the mechanism was. And what we found is that within this N-terminal region of PAR4 is a domain called the VASA domain. This domain is important because this can be a binding site for E3 ubiquitin ligase, and I'll tell you the importance of that in a minute. But what we did is we took the amino acid region right around it, and we designed a 16 amino acid peptide. So this peptide will produce apoptosis now on its own. So this would be the factor that's really responsible for it. And so if we use a mutant of this, it doesn't produce apoptosis in these A549 and H460, which are both lung cancer cells. So what we had done was we were able to map this to the VASA domain, the sequence right around the VASA domain, so that in the future now we could use this to target the resistant population. So the mechanism then, PAR4, which by itself contains this VASA domain, ELNNN domain, this is sequestered by this E3 ubiquitin ligase, and subsequently, because this ubiquitin ligase, which is FBX45, binds to it, it undergoes degradation through the proteasomal degradation pathway, and it prevents apoptosis. Now, on the other hand, when you have this 16 amino acid fragment, or even the PAF domain, basically what happens is it acts as a decoy. So it's able to bind to the E3 ubiquitin ligase, FBX45, and now, because the ubiquitin ligase is sequestered, you first of all have free PAR4. So now this free PAR4, which is intracellular, endogenous PAR4, can translocate into the nucleus, and it can produce apoptosis. So that is the mechanism by which this works. So PAR4, by the way, is a tumor suppressor. This is expressed ubiquitously in normal cells. It tends to be mutated as expected in some of the tumors. It's also downregulated in a lot of cancer cells, or it can be inactivated by phosphorylation. We've made PAR4 knockout mice, and these mice grow spontaneous tumors in various tissues. And also, we've made transgenic mice. These mice overproduce PAR4 in all the tissues of the mice. And these mice are resistant to both autochthonous as well as non-autochthonous tumors. The important thing about PAR4 is that it is intracellular as well as extracellular. So it has intracellular roles in the cytoplasm as well as in the nucleus. Or extracellular, it can be secreted. Now, when it's secreted, it binds to cell surface GRP78, which is present primarily on the cancer cells, not on most of the normal cells, and so it can target the cancer cells. But the problem remains that you now, like I showed you in the previous slide, you need intracellular PAR4 for the action of extracellular PAR4 or that PAF domain. So first of all, we made sure that if we were to say just go ahead and overexpress PAR4 in the tumors, we could get an effect in the tumors. And what we've done here is grown xenografts in the flanks of mice, injected the one in the left flank here with the control adenovirus, or the one in the right flank with the PAR4 producing adenovirus, and then followed these mice over a period of 21 days. And what we found is that the tumors that were transduced with the control adenovirus continued to grow, whereas the tumors that were transduced with the PAR4 producing adenovirus underwent shrinkage. And this was because of tunnel positive cells, apoptosis going on in these in the tumor cells. Now this is quite dramatic, as you can see. This is just one intratumoral injection. Now this was done at a time when we did not know that PAR4 is actually secreted. So we call this a bystander effect. Now that we know that PAR4 not only has an intracellular role but also is secreted, this makes a lot of sense because the transduction frequency of the adenovirus is barely about 25 to 30%, whereas we are getting more than 85% shrinkage of these tumors. So this work is also published. You can take a look at it in Cancer Research. This is another paper in Cancer Research. And basically what this told us was that if we were to overexpress PAR4, we could cause apoptosis, just by that molecule. So now, if we were to try and introduce PAR4 from outside, say with either the 16 amino acid domain that I mentioned to you, or even full-length PAR4 or PAF, it's going to require intracellular PAR4. And so now many of these cancer cells do have PAR4. It's mutated in only some of them. So the strategy that I described is going to be useful in quite a few of those cancer cells. But the question you're going to have is, well, it's a tumor suppressor, so how do you target those tumors where PAR4 is mutated or not active? So that's where we decided to take a slightly broader approach and ask whether we could find a molecule which could kill cancer cells which are deficient in PAR4 function and as well as P53 function. And the long and short of this study that we did is that we looked for FDA-approved drugs, because we wanted to take them quickly to the clinic, FDA-approved drugs which could target a broad range of resistant cells. And we found Avastin, which is an antihistamine drug. Unfortunately, Avastin has a very high IC50. It's in the range of 20 micromolar, which didn't really conform to the requirement that we had in terms of drug development. And so we decided to make analogs. And we were fortunate that one of these analogs worked in the range of 1 to 3 micromolar, depending on the cancer cell line. And as you'll see here, it basically works in that range of, this is 2 to 3 in this particular background. And we also did a PRISM analysis. This is where you send your small molecule to Broad Institute at MIT, and they do a screen of your compound on 900 plus cancer cell lines, and then they give you the report. And what we found is that more than 95% of the cell lines were sensitive to this particular analog that we are calling super Avastin. Now, by the way, I mentioned that we were looking for a molecule which will also kill the cells where PAR4 function is not present. So one of the things that we did is we took these A549 cells, used the wild type, and this molecule does cause inhibition of viability in those cells. We also made a knockout, a CRISPR-Cas knockout for PAR4, and again, this molecule is effective in those cells as well. So now a broader range of cell lines. These are prostate cancer cell lines which are resistant to enzalutamide. This is the second generation treatment for prostate cancer. Also castration resistant cells. These are usually androgen independent. We also made enzalutamide resistant derivatives, and they were sensitive. And then this particular cell line, CWR22RV1, has a mutant form. It's a truncated form of the androgen receptor. They call it ARV7. And again, these cells are actually not dependent on androgen, because by itself, this androgen receptor mutant can enter the nucleus and cause a transcriptional activation of downstream events. And these cells are also sensitive to superibastin. Now, normal cells are not affected by this. And then also, we looked at the plasticity occurring in tumors. So basically, once we knew that we were able to target more than 90% or 95% of the cells that were screened by the Broad Institute in the PRISM analysis, it was obvious that we were able to target tumor heterogeneity, because this is not only intertumoral heterogeneity, but also intratumoral heterogeneity. But we wanted to see what happens if we can actually target plasticity that was induced in tumors. So we induced plasticity in A549 cells, and this again, the cells were sensitive to the action of superibastin. And basically the same thing with LNCAP cells. The plasticity, by the way, is attributed to neuroendocrine lineage that these cells convert into. And so again, we found that those cells were also sensitive to the action of superibastin. These are osimertinib-resistant cells. Again, they are sensitive. You've heard that in one of the discussions earlier. So they are also sensitive. The picture I'm trying to portray is that we've looked at the broad range of sensitive cells or resistant cells, and they're all sensitive, although it doesn't seem to be effective in the normal or immortal cell population. What is the mechanism? The mechanism is through, I'll give out the answer and I'll tell you how we found it. It's through S6K1. So it inhibits the phosphorylation of S6K1 by mTORC1. mTORC1 is not affected. Some of you might wonder if mTORC1 is affected, you know about the feedback loop. So this is downstream, which makes it even better as a target. So we found the target through phosphokinase antibody array, and basically we found that within 3 hours we were able to get downregulation. This is a fairly early event, because if you want to really see the action of a small molecule, it tends to, especially when it gets into the cell, it works within the first few hours. Also, we collaborated with the molecular computational experts at our university. They were able to confirm that superibastin actually does bind to S6K1, but this is all in silico. You have to verify that in experimental studies. And that's basically what we did. We prepared a bioactinated derivative of superibastin, and with that we were able to pull down S6K1. So this told us that this did not pull down S6K2, which meant that this was fairly selective in its binding to S6K1. And it works beautifully. We've looked at a broad range of xenografts. It works beautifully in inhibiting the growth of these tumors. These cells here, KP7B from Tyler Jack's group at MIT, these are P53 minus and also KRAS mutant. So like I mentioned to you, this is one of the examples where P53 is missing, but the drug works. And these are prostate cancer cells. These are actually castration-resistant and enzalutamide-resistant cells, which basically don't grow in the presence of superibastin. Now, is S6K1 really important in the growth of tumors? The answer is yes. What we've actually done here is used A549 cells that were knocked out for S6K1 by CRISPR-Cas. And the control cells here, so the control cells grow, as expected they form tumors, but the S6K1 knockout cells are not able to form tumors, indicating that superibastin, which inhibits S6K1 at the phosphorylation level, which is the activity, it inhibits the activity of S6K1, is effective, because if you don't have S6K1 activity or function or expression for that matter, as shown here by the CRISPR-Cas knockout, you are not able to get growth of tumors. So what's the mechanism? Basically what happens is mTORC1 can cause phosphorylation of 4-EBP1 and phospho-S6K1. And when it does that, you get cap-dependent protein translation. That leads to proliferation, cell survival, and tumor growth in mice. Now, on the other hand, what we found is that superibastin prevents the phosphorylation of S6K1 by mTOR. It doesn't inhibit mTOR. All it does is, like I showed you, it binds to S6K1 and prevents its phosphorylation. So it doesn't reactivate any feedback mechanism. So it just inhibits S6K1. The other thing, by the way, is if you inhibit mTORC1, one of the drawbacks there is that you can activate autophagy, and autophagy can prevent the action of some of the chemotherapeutic agents or even radiation for that matter. And so when S6K1 is inhibited, CDC42 and RAC1 are not active, phosphoPAC1 is not active, and that leads to the disorganization and destabilization of actin, and this leads to activation of caspase-2, resulting in apoptosis and inhibition of tumor growth. Each one of these steps is provided evidence in the paper that has been recently published in January now. And so if you have a chance to take a look at that paper, you'll see what were the experiments that were done to look at each of these steps in the pathway leading to caspase-2 activation and apoptosis and inhibition of tumor growth. So our future directions, we are interested in basically looking at what are the predictors for response to treatments in general, but in particular to the 16 amino acid peptide, as well as to superibastin. Some of the members from my group involved in the study. Thank you.
Thank you, sir, for such an illustrious talk on part 2, part 4, and superibastin induced overcoming or the tumor resistance. Thank you so much, sir. Any questions from the audience? Thank you.
Thank you.
Now I would request Ankit sir to facilitate the speaker with the momentum. And lastly, I would request Dr. Murli M. sir to facilitate the chairperson of this session, Dr. Ankit sir. Moving on to the last session before lunch. World Cancer Day is a day to remember those who fought bravely. Cancer survivorship is a journey of resilience and hope. It's about embracing life after diagnosis and treatment, finding strength in overcoming challenges, and redefining what it means to live fully.
Now, I would like to invite the chairperson of this session, Professor Dr. Neel Kamal Kapoor, Chairperson IHEC, AIIMS Bhopal. The topic of the lecture is Realizing the Promise of Precision Oncology in Clinical Practice. Please, ma'am.
Professor Neel Kamal Kapoor, she is the chairperson of IHEC AIIMS Bhopal, and she has been a professor and head of Department of Pathology before, and she has many WHO and Rotary fellowships. Besides medical science, she also has her interest in literature and has been awarded with Sushma Tiwari and Tulsi Sahitya Samman. And she has a varied area of interest in surgical pathology, anatomic pathology, and cancer diagnostics. Now, I would request our chairperson, honorable chairperson, to kindly invite the speaker of this session.
Thank you very much for having me here. And for this next talk about advancing cancer care through precision medicine, which is the, I should say, the talk of the day for some people. I invite Professor Saket Das, who is a faculty here at AIIMS Bhopal. He's an additional professor in Department of Radiation Oncology and also Associate Dean, Nursing and Allied Health Sciences. Also, he is the member secretary of AIIMS Bhopal Tumor Board. He's got 75 publications. He's a fellow of Indian College of Radiation Oncology. He's a member of Royal College of Radiologists, London, and a member of National Academy of Medical Sciences of India. And his areas of interest are radiation oncology and biomedical engineering. Professor Saket Das, may I request you to carry on with your talk?
Thank you, ma'am. So I think from morning we are having lot of lectures on precision medicine, but please relax, I am not going to talk about any signal transduction pathways or molecules, we had enough. So the topic for me is little long and difficult. This is realizing the promise of precision oncology in clinical practice. Now, as clinicians, when we talk about precision, the word that comes to our mind is decision. We are always making some decision or other, either in our clinical diagnosis or in therapeutics. Now, the question is how precisely or how accurately we are able to make this decision. Okay, so let us start with this hypothetical situation. So two doctors, Dr. Skepticus and Dr. Eclectius. So they are in the process of making a clinical decision about the patient. Now, the pathways that they are following are like this. So Dr. Skepticus takes as much variables as required. She weighs each and every variable because according to her, all the variables have some meaning and it is potentially connected with the decision. So in that process, the central tendency is found out following the Bayesian inferential statistics, and then you come up with a model. That model kind of explains some variable deviations, that is called explained part, and there are some unexplained parts. And this you can extend to more number of variables, like you can increase the number of variables. And what essentially she does is, she takes n number of variables and comes up with this model. I think all of us are aware this is a very classical regression model. Now you see these regression coefficients here. These regression coefficients actually can take the probabilistic value from 0 to 1, any numbers. What that conceptually will mean that today we are meeting here, that probability is 1. Some of you have come from Mumbai, some of you have come from US. So you started with a probability of 0, and then as you approach, your probability increases to 1, and it takes any values, does not exclude any value. Now, what essentially comes out is a goodness of fit data. So it so happens that this method is robust to make a very good fit of all the past experiences. As far as the new data set is concerned, it may fit and some points may not fit. Now this is one approach. What Dr. Eclectius does, he takes a different approach. So his decision making is based on encounters which are clinical experience. Now these experiences have some discriminating value. This takes two probabilities, 0 and 1. And if it is 1, that is included in the model. If it is 0, that is excluded in the model. We are all aware of this kind of algorithm models. We are using it, ST segment elevation, yes, no, yes, in the coronary care unit, no, then evaluate some more criteria. Essentially, the degrees of freedom in the previous model was n-1. But here, depending on the number of criteria you have, your exit numbers will be n+1. So this is kind of a fast and frugal tree model. Now I am not going to discuss which is best or which is better, but essentially both are trying to project some future predictions based on past experience. And here this is actually the basis of rationality. So in one end, you have all the informations of the world by which you make a rational decision, what we would like to call as unbound rationality. On the other hand, you have limited information by which you make a decision, and your optimization method lies somewhere in between where you make it ecologically rational. Now, I'm not going to bring the other parameter of statistics here in much detail, that is the constraints. If you see the number of constraints, then in your rational model, it so happens that the self-imposed or correspondent constraints will be more, and in the other end, the constraints are less. But studies have shown both the models in different situations can work more or less equitably. So the question is, how much information, how less information, what is the optimized information that we are going to look for to make a clinical decision? Now this brings us to one very important concept which we deal every day, 2 into 2 table. We are all familiar with this 2 into 2 table, whether we are diagnosticians or clinicians. It is so impressed in our mind that everything we judge as true positive, false positive, true negative, false negative. And if we look actually the history of medicine from antiquity, this is there. And whether medicine is coupled with magico-religious, whether it is philosophy, whether it is science, whether it is technology or personalized precision, it is the 2 into 2 table or true positive, false positive that has been the dominant philosophy behind that. Now this brings the question of precision in mind. Depending on this, you will say that this is more precise than that because we are getting more numbers in the true positive cell. It also is there that it is linked with the cognitive ability, the amount of information that human brain can handle. Now this cognitive ability and this information burden may be related somewhere like this conceptually, and there may be some area where these things get optimized. Now this concept is very pertinent in making the decision as far as the precision medicine is concerned. And from morning we have heard what has happened actually, the disease has changed the dimension. From the histopath, from a phenotypic details, it has gone to molecular. Oncology is one of the earliest branches that embraced precision medicine. And you can see here starting from single point mutations to deletions or insertions, to copy number variations, to duplications, to gene fusions. Everything are now being looked into, and there are so many methods of laboratory that can be explored. Some of these are seen here, PCR, MLPA, SNPRS, etc. What is the outcome of this? The outcome of this is the concept has changed. The traditional ideas of clinical trials are now being questioned. What essentially we do in clinical trial, we have a cohort or group. We sometimes stratify them based on certain variables. But now we are facing the challenge that we have n number of variables. And then we know that tumor is highly heterogeneous. It is not only heterogeneous in the tumor, it is not only heterogeneous in the matrix, it is also heterogeneous within the cell. So how to bring those heterogeneity in our clinical trial to generate evidence is a very, very challenging issue. Now, the outcome or fallout of this has been something like this. The disease is now expanding centrifugally. If you look at breast cancer as an entity, invasive ductal cancer, there are 4 types of that. Even in these are different as far as the clinical presentation is concerned, metastatic potential is concerned, pharmacological sensitivity is concerned, even overall outcome is concerned. HER2 positive breast cancers are highly chemosensitive. They respond to trastuzumab, they metastasize to bone, and these examples are there in abundance, and we have heard some of those in our case discussions and in the morning lectures. So the concept now has been umbrella of disease. So based on this pathological entities, and based on these molecular classifications, disease is now considered as an umbrella of combinations. Now, whether it has really led to the improved outcome of the patients, we will see that shortly. But I don't need to go through these next 2 slides because the list is going longer and longer. Like you have a target, that means some driver mutation. So you have a train, there are mutations. Some of these mutations are actionable, that is, the train is being driven by the driver, and there are passenger mutations which are not so much targetable at this point of time. But there are so many molecules which are now developed for these targets, and in potentially these are actionable. Now, the question is whether this is leading to improved outcome. The early indications say so. This is a study which is published very recently in metastatic or advanced cancers, where targeted versus non-targeted therapies had shown significant difference in a small number of patients. But I am sure in future we will get more evidence to evaluate this. Now, if you look cancer as a genomic model, clinical oncology, diagnostic advancements, and precision oncology, these 3 had become actually a very powerful combination to change the clinical practice. Technologies have advanced so much that you are not only able to do NGS to sequence the entire tumor, you can actually sequence a single cell, something what is called single cell sequencing. You can edit the DNA by CRISPR-Cas, a very powerful technology by which you can actually edit and repair, potentially repair that. Epigenomic changes like histones or methylations, these are very powerful tools for targeting the genes or targeting some of these diseases. Now, what has happened here is something which is a paradigm change, that is integration of these different platforms, what is called multi-omics. So you have genomics, transcriptomics, proteomics, and metabolomics, and technology is also there to integrate these different techniques and to generate biomarkers or therapeutic targets to facilitate the drug discovery. Now, I am not going to deal that in detail, but here I would like to touch upon one important thing. This kind of big data analysis actually use very paradigm concepts. For example, convolution. It is a very powerful mathematical operator. It is like you are experiencing a seismic wave at the surface. Now that wave is generating very much center towards the, and coming through many layers. So the information that is contained in one layer is actually dependent on the information which is present in the preceding layer. So a signal which is related to a process, it is possible to derive the original based on what is being measured. So this is the concept of convolution. And second thing is the traditional inferential statistics concepts are also being changed or questioned. Here you see you have some variables, and these variables are having different numbers. What we traditionally do is we compute a mean of this. Now we assume that mean actually represents all these variables. And then we have another group and we make the statistical test to compare the means. We know all this like our t-test, so many other tests, and then we get the sacrosanct p-values, etc. But these methods are not sufficient to handle this kind of big data. Here we have different parameters. These parameters can be n. For example, if you think of the rows, these rows can be miRNA expression, SNP expression, whatever. You name the biomarkers, it is there. And you have 2 groups. And then each patients are there in these 2 groups. So essentially now what you will do is you compare 1 with 2, 1 with 3, 1 with 4, 2 with 3, 2 with 4, so on and so forth. And then you come up with a probabilistic rainbow model, like you have 0 to 1 and then you have a cutoff. That cutoff is also decided based on your data inside analysis. And then you come up a heuristic model of that. So each measure of this kind of model gets an importance which is not included in the traditional statistical concepts. Now coming back to the question of clinical trial. clinical trial is undergoing a paradigm shift. What was the idea before is you have two groups. Now, in this case, actually, Dr. Eclectius is having a very hard time. The reason being that you have two groups, and these two groups you balance, and you balance some parameters. Now, after balancing those parameters, you measure an outcome based on certain encounters or intervention, and you say that, look, my outcome is related with this. But when you have so much of heterogeneity, when you have n number of variables, then it is very difficult to balance unless imagine you have some twins who start from one and then undergoes the same proportionality of the hazards, but one of them encounters some experience, others don't. So that is what is the classical idea of the Cox proportional hazard model. Now here it comes to n of one trial. That means each patient, the heterogeneity and the variations of these patients, they become their own control. And there are many statistical designs which are coming out, which are very powerful technology. It is focus is being shifted from the cohort to the individual, from the group to the person. And this is a very important step in the personal medicine. And as I said, digital twins. This is also a very powerful technology for the in silico discovery of the targets and the drugs, where you can model the heterogeneity of different dimensions and then actually see how this is fanning out. But everything is not very smooth at this stage. We are aware of the Gartner's curve. The Gartner's curve is something that when a technology is introduced, how long it takes to come to the peak. For example, if I give example from my domain, the Monte Carlo was discovered in 1948. It started being used in radiation oncology in 1972, a difference of almost 30 years. The CT scan was discovered in 1970s and it peaked around 1990, around 20 years. NMR was discovered in 1948 and it is being peaked around 1980s, around 30 or 40 years. But if you look at AI, the concepts were of 2016, now it is boomed. Precision medicine also same. So the duration of time of introduction of the technology to coming to the clinical practice is being reduced. LMIC countries face peculiar challenges. From this graph, actually, you can see that most of the Western countries, they are having these centers, but this is one area where the equitable access of the precision medicine benefits to the population is challenging. Now I will touch some of the issues related to India. India is a very diverse country. Almost around 18 lakh cancer cases are diagnosed every year based on the 38 population-based cancer registry that we have, which covers around 10 to 15% of the population. 80% of the cases present late, 20% present early, 80% of them are not curable in that sense of the term. 20% of the patients default. India produces one Australia every year. Even if you go based on the addition of the facilities which are there at this point of time, in next 20 years also we are not going to make the cancer services accessible to all the population. So therefore, what is the public health intervention that is required to bring these benefits of the science and technology to India remains to be looked at. Here you see this heat map. This is to access of clinical trials. And you can see there is a wide variation between the area where the disease is high and the number of clinical trials that is being run. For example, this part of the country has one of the highest incidence of the tobacco-related cancers, but the tobacco-related trials, patients getting benefit of the trials there is a wide gap. Molecular tumor board is one of the way by which we can implement these things at the institutional level when the options are limited, when the cost is a factor, when the standard of care has been exhausted. These are multidisciplinary boards which include not only physicians or surgeons or radiologists or pathologists, but also basic scientists to come and interpret that. Ladies and gentlemen, today is a very special day. This is World Cancer Day. And in this World Cancer Day, we actually celebrate survivorship. Now, as an oncologist, to me, survivorship is associated with Kaplan-Meier survival curve, where we plot the lives and deaths, right, censoring, etc. But I would go beyond that. I would say that what is the promise? The promise is of one very powerful outcome that is favorable. This can be survival, this can be local disease-free recurrence, this can be quality of life. So favorable outcome is the single commitment or promise that any science and technology, or for that matter, any initiative would have. Now look at these pictures. These are not pictures, these are symbols in the truest sense of the term. These are the handprints of the soldiers who had fought against the emperor of maladies. These are soldiers who did not leave the battlefield, who did not mark their days with red in the calendar, waiting for these days to end. They have fought in their frail body, in their devastated mind, for favorable outcome. And the way they have done, through complete submission of body, mind and soul, dignity and entirety to another human being. This is what makes this fight strong. This is what makes this fight unique. And this is an expression of a very complex emotion, empathy. Now this emotion is all pervasive. It goes beyond all dimensions. It transcends the time, space, goes to our consciousness, where knowledge undergoes convolution. Knowledge undergoes a mathematical change, if you can say, to wisdom. And this is the wisdom which produces one of the enigmatic force of the nature, that is of the hope. And unlike trust, hope cannot be breached. It takes only one value, that is true positive. And if you add this true positive to this 2 into 2 table, you cannot but have this outcome favorable. It is this hope that helps humanity to realize the dreams, if not here, somewhere else, if not today, some other day, on some beautiful shore. It is this hope by which a mother of a brainstem glioma child sees a day that is, sees a land that is brighter than a day. It is this hope that reverberates from the ashes of Auschwitz to Helsinki to the Georgetown mantra, that is autonomy, beneficence, non-maleficence, and justice. This is the one powerful force by which the humanity ascends, human being evolve. And that is what is important. Now, ladies and gentlemen, I cannot show you in that plane any metric, any parameter. But if I had to show some metric in that hyperplane, I would have shown that they were all equally precise. Non-parametric, distribution free, standard deviation of 0. It is this legacy that makes us unique. It is this that brings us to the theme of this World Cancer Day. It is this that we celebrate, that we are not subdued. We are not afraid of the heart to be broken, but we repair it with gold, with the precision of science and dignity of humanity, so that the last molecule of life can reverberate to resonance. So with this, I end. Thank you so much for this.
Thank you very much, Dr. Shaikat Das, for this amazing, wonderful lecture, which began with precision is decision, and which ended in the universal ethics, and all through the myriad aspects of science and statistics and so much more. So thank you very much. Any questions from the audience? maybe you've been given a lot of food for thought. You'll chew it over, digest, and then come back with questions. But Dr. Shaikat is very much here to answer your questions. So thank you so much, Dr. Shaikat. With this, we conclude this session.
Thank you so much, sir. It is a perfect way to end the scientific program. What a wonderful lecture. Now, I would request the chairperson of this session kindly come on the stage and felicitate the speaker of the session. A round of applause, everybody. Now I would request Dr. Vipin Kharade, sir, to felicitate the chairperson of this session. Thank you so much, sir. Thank you so much, ma'am. The scientific program today ends here. I would like to express my sincere gratitude for all the speakers and guests for sharing their experiences with us. And I would request everybody to proceed for the lunch. Thank you, everyone. Hall. I repeat, lunch will be there in CMAT Hall. Same floor, CMAT Hall.
So you can follow Dr. Anas. He'll take you to the lunch area. And for the workshop, I think you have already registered for, you've given your preference for the workshop. So after lunch, we'll guide you. There you can either find me or Dr. Anas. We'll guide you whether the workshop is regarding radiation oncology or regarding 3D organoids. So accordingly, you have to go to that specific venue, and we'll again assemble after the workshop is over at around 4:30 or so for the valedictory session. Okay. Hello. Good evening, everyone. So we come to the end of the long day of workshop with brainstorming on so many aspects of cancer, and followed by 2 workshops. So we will, Dr. Debashish sir and Dr. Sekat sir, I would like to invite them for the, for giving the certificates to the participants. So Prashant sir, also you come. So we will start with the students and the delegates who participated in the hands-on workshop on radiation therapy. I'll just call upon your name. Amina Mughal. Oh, then you call her. Arun Das. Athira Mohan. Vani. Vani. Bushra Ansari. Gajendra Singh Yadav. Naveen. Pranay Kurhade. Naveen. Priyanka Kennel. Raj Bhagat. Rapolu Rudra Sanjeev. Sakshi. Sakshi is here. There are 2 Sakshi, Sakshi and Sakshi Singh. Are you Sakshi Singh? Who is Sakshi Singh? राज भगत किसी और को दे दिया क्या? Sakshi Singh. There is one Sakshi Singh. Shekhar Gupta. Sivamani. Shekhar Gupta. Sivamani. Venkata Hemant. Hamdan. So I assume that the rest of the students will come and collect the certificates from us later on then. So now coming to the 3D. Hamdan, okay. So next we come to the participants who were in the 3D organoids workshop. So Abhishek Soni. Ashish Shinde. Ashwini Thombre. Chandrasekhar Yadav. Harsh Khushwaha. Megha Bhagel. Mr. Harsh. Megha Bhagel. Motsim Arif Ali. Neha Gupta. Palak Rajput. Poonam Kumari Pathak. Ramsha Javed. Rishika Das. Ramsha Javed. Rishika Das. Rishika Das is not here. Shraddha Mahajan, Shraddha Mahajan, Shubham Dangi, Shubhi Chaurasia, Shubham Dangi, Shubhi Chaurasia, Miss Tanvi, Miss Tanvi, Pakiresh Reddy, Pakiresh Reddy. Anyone is remaining? Priyanka. हेमंत तो है ही नहीं. हाँ हेमंत का तो नहीं है. मैंने अनाउंस किया फिर किसी के पास चला गया. Has it gone to someone? Hemant certificate, please check. I doubt. अरे आपसे पहले हो गया था. I never. अरे आप थे ही नहीं जब हुआ था. कहाँ जा सकता है सर? ये आना चाहिए. तो बन जाएगा.
बन जाएगा. ये हेमंत.
और किसका रहेगा? ये? Wait, please. Okay, Rapolo Rudra Sanjeev, उधर से आ जाइए. आपका? Okay, Gajendra Singh Yadav. Bushra Ansari, Arun Das, Amina Moghul. These are remaining. Have they come? Pakiresh Reddy, not here. Shraddha Mahajan, not here. Motsim, they left. तो but sign लेना पड़ेगा ना. We should take their sign ना. आपको दे देंगे, बाद में दे देंगे, ठीक है? Okay, so organizing. रिसोर्स पर्सन्स के दे दें. ये तो चलेगा. राहुल अग्रवाल. डॉक्टर प्रशांत चौरे. दीप्ति मैम इज नॉट हियर. डॉक्टर मुरली. डॉक्टर जितेंद्र सिंह. उनका भी बना ही नहीं है सेक्ट.
मैं कर दूं अनाउंस. किसका
हो गया?
किसका?
डॉक्टर सैकत दास. महादेव सर का नहीं है. अभी रुक जाओ, पहले सर ये करिए.
डॉक्टर नेहा.
डॉक्टर गरिमा गोयल. गरिमा मैम गई.
Okay.
Dr. Prashant Chowre once again. Organizing committee. Resource person. Dr. Murali. बाद में.
हाँ.
इनको चाहिए.
बाकी
people who were, students who participated in the workshop And the ones who were the resource persons for the workshop, especially Ms. Muskan and Ms. Pallavi, Ms. Sayantika, they were involved in the workshop from organoids. So radiation mein.
So, I mean, all the junior residents and senior residents, we had two simultaneous program which was going on. Dr. Nishtha, Dr. Hemant, Dr. Priyanka, Dr. Arvind, Dr. Anas, and then all supporting staffs. And Dr. Vipin, he helped a lot for the conference workshop. And I thank all the staffs and the participants who stayed throughout the day. So thank you.
So before we end, I request you all to join us for a cup of tea, and maybe few participants can come for the feedback, if they can tell us, give us some feedback regarding the CME today and the workshops. Anyone? The one who've come from outstation, from Manipal, all the way from Manipal, come.
Hello. Okay, this is my first time, like I have come to Bhopal and I really love the weather. The place here is really nice. And regarding the workshop, yeah, this was my first experience handling cell lines. It was good. Especially the panel discussions I really liked because it was the multidisciplinary thing where I could understand the multiple drug resistance. And yeah, thank you. On Mahe, it's like really a good opportunity for me to come here. Thank you, everyone.
Thank you so much. Anyone who attended the radiation workshop, you want to give feedback?
Hello. Yes, everyone. So myself, Dr. Shekhar. I'm currently working in anatomy department. And considering the fact that the panel discussion, as we all know, it was the best part of the whole workshop, I guess. And apart from that, we went to the radiation therapy department. And we got to know like a lot more in details. A lot of things were not known to us, like how it is done. And we just knew like this is the procedure, like brachytherapy is there, it is for cervical cancer, so and so. But getting to see that and like figuring out like how they are doing it, it was quite interesting, and I really enjoyed it, and it was actually surprising for me. A lot of things were new to me, so I enjoyed it. Thank you so much.
Debashish sir, would you like to just finish the event? Okay, so
I came up simply because it was I who welcomed you all, and so it's my say goodbye as well. So, yeah, thanks to the organizers because they are meant to organize. I shouldn't thank them in particular, but many thanks for you all. Don't expect to learn everything in one go. It's a long process, but it's important to stay stuck in the job of learning, to stay stuck in the path of learning. And if you are willing, there is no force in the world which can stop you. So good luck to you, and I wish to see each one of you grow up to be a very promising oncologist. Thank you.
thank you, sir. So the tea is waiting for all of us, and the ones who have left, their friends can collect the certificate from Miss Muskan, and we have some reading material for the organoid workshop. So you can, the ones who were involved in the organoid workshop can collect the reading material from Miss Muskan. She'll be giving pen drives, so you can take from her.
Okay, so thank you, everyone.
ये बोल रहे हमारे नाम के सामने डॉक्टर लगा दो, सब MBBS हो गए ना, तो वो हाँ शी विल डू